Welcome everybody to our Spring 23 Symposium on Sleep and Shift Work Implications for Worker Health and Safety. This is one of our 2 annual symposia that our institute hosts per year, and we're thrilled to focus on this topic this year. I'm Stephen Shea, Director of the Oregon Institute of Occupational Health Sciences. I use pronouns he and him, and I'm a researcher studying the biological basis behind changes in disease severity across the night and day, including the adverse health effects of shift work. Today, I will introduce the keynote speaker, facilitate the first panel discussion, and keep the timing in the morning sessions. Dr. Saurabh Thosar will introduce other speakers and facilitate the afternoon workshop at the end of the day. There'll be some housekeeping rules I'd just like to review for a moment. I may have to review this later again as more participants attend, but when speakers are presenting, it's probably best if you turn off your cameras and microphones. It may help with the bandwidth. The symposium will be recorded, and I believe all of the presenters' slides will be available after the symposium. Throughout the talks, it would be best if you use the chat function to share your thoughts and ask questions, and we'll be monitoring the chat through the day, and we hope to have time for questions after each presentation. And at the end, during those questions and discussion parts of the program, we will enable cameras and microphones so you can actually speak in person if we have the time. There will be a few short breaks and a longer lunch break at noon, that's Pacific time, so it's lunch for people over on the West Coast, late afternoon tea break for others. We want to remind you that there will be SHRM professional development credit, so that's safety, health, environment, and risk management credit for those who like it. And at the end of the day, please check with Amy Spring, one of the organizers, and she'll provide that credit code. We'll also have an event evaluation, and Amy will post that link throughout the day, so please take a moment to complete it. It will help with our future planning. And periodically we'll put the agenda in the chat box so that you can see where we are in the program. But as I said, we'll start off the program with a keynote speech and presentation, sorry, and then go on to a panel discussion. And the keynote speaker, Professor Charles Czeisler from Harvard University and Harvard Medical School and the Brigham and Women's Hospital, will be in that panel as well. So just to let you know that our institute tries to bridge science and practice, and this is obviously an interesting and useful challenge. We've attempted with today's program to bring you science in a way that informs practitioners, and we'll bring you conversations with workers and practitioners that allow us to make the science come alive. With that, I really don't think we could have chosen a better person to introduce the day with the keynote address, Professor Charles Czeisler. His title is Sleep, Circadian Rhythms, and Occupational Health and Safety. I think there was an addendum to that saying something like Foundations of the Field. And that's appropriate. Professor Czeisler is the Baldino Professor of Sleep Medicine at Harvard Medical School in Boston, Massachusetts. He's Director of Sleep Medicine at Harvard Medical School and Chief of the Division of Sleep and Circadian Disorders at the Brigham and Women's Hospital in Boston. Dr. Czeisler has more than 40 years, and I just spoke with him earlier, and he said next month is the 50th anniversary of his first blood sample to measure cortisol in somebody during sleep, 50 years ago almost, so congratulations on that. But Dr. Czeisler has more than 40 years of experience in the field of basic and applied research on the physiology of the human circadian timing system and its relationship to the sleep-wake cycle. He's served as the team leader of the Human Performance Factors Sleep and Chronobiology team of NASA's National Space Biomedical Research Institute. And that's responsible for developing sleep-wake schedule guidelines for astronauts and control people during their space exploration. Professor Czeisler also served on and consulted to a number of national and international advisory committees, including the National Institutes of Health, the Institute of Medicine, the National Academy of Sciences, the Sleep Research Society, the Nuclear Regulatory Commission, the Air Force Office of Scientific Research, the Air Transport Association, the Federal Motor Carrier Safety Administration of the United States Department of Transportation. Professor Czeisler served as a special consultant to the Massachusetts Special Commission on Drowsy Driving and was elected as chair of the Sleep Disorders Research Advisory Board for the National Center on Sleep Disorders Research at at National Heart, Lung and Blood Institute. So that's a lot. And last night I was reading through Professor Czeisler's more than 100-page CV. And that's a very, very brief distillation of some of it. But what's not on his CV, I want to share with you now. This is Professor Czeisler and me. So when I showed this to somebody yesterday, they said they didn't recognize me. So I've actually put on the same shirt so that to prove it's me on the right. What's interesting about this, it shows that I've collaborated with Professor Czeisler for a long time, and we had a good time. And this was at 4:37 in the morning during a grant review process in Washington, D.C. We proved that we can stay awake and alert and happy across one night. But today, of course, we're going to talk about a lot of people who have to endure that every night. Maybe they won't be so happy. And anyway, so that was great for me to dig up this photograph. It pleases me anyway. But one of the things regarding how long Professor Czeisler has been in this field, I remember talking to him when I first came out to Oregon, and he talked to me about, oh, I've done lots and lots of occupational health research, and this was a paper from 1982 in one of the most prestigious journals called Science, called Rotating Shift Work Schedules That Disrupt Sleep Are Improved by Applying Circadian Principles. And Professor Czeisler did this research showing that gradually changing the shift schedule is better than jumping to night shift work in one fell swoop. But when Professor Czeisler told me, or Chuck told me, that, well, when I tried to sell this or inform the people, the management, this is what they said. They said, well, if you're going to cut the tail off a dog, here in Texas, we prefer to do it in one go rather than 6 inches at a time. So this is really an example of the problem that we have before us. It's science and practice coming together. So with that, I think I should pass the mic to, I will stop sharing my slides, and Professor Czeisler will now begin to share his slides and start his presentation. Over to you, Chuck.
Well, thank you so much for that very kind introduction, Steve. I love that photograph. I'm going to ask you to send that to me. And can you see my screen now?
Yes, we can.
Okay, great. And it reminds me of the wonderful time that we had working together those many years. And I just want to note that we did get that grant that we were up for the site visit preparing for. So yes, I'm going to be talking about sleep, circadian rhythms, and occupational health and safety today, and I really feel honored to have been invited to deliver this presentation this morning. I do want to disclose that I have been involved with the development of the 3 currently approved FDA-approved treatments for circadian rhythm disorders, and the first 2 relate to shift work disorder. One is modafinil for shift work sleep-wake disorder, and the other is armodafinil for shift work sleep-wake disorder, which were developed at the time when we did those trials with Cephalon, which is now owned by Teva. And I have a number of other applications because I do try to work hard to apply the work that we do, the basic research that we do in the laboratory. And those are indicated in the disclosure here. I also want to acknowledge the many people with whom I've had the pleasure of collaborating, and I'll be presenting results from many of the people in this group, including, as you'll notice here, Professor Shea, who was a longtime collaborator, and we have been supported by many different federal and non-federal agencies. The first study I'm going to talk about, Professor Shea gave me quite a remit here today, in which he's essentially asked me to review my my entire career in a 50-minute interval. So I'm going to go a little bit fast, but I'm going to start with this finding, which was quite exciting to us when I was doing research studying people living in an environment free of time cues, where there are no clocks, no radios, no information sources as to the time of day. And people were living there for 1 to 6 months when we were doing these studies. And what we noticed was that under certain circumstances in which these individuals were going to sleep at all different biological times of their internal day, which we could track using various hormones and other physiologic markers of their body temperature. So those physiologic systems were continuing to oscillate with a near, very close to 24-hour period, but the timing of when they slept and woke was sheared apart from that. So they were sleeping and waking at all different times. The amazing thing is when they went to sleep at all different biological times of day, which are indicated by the clock hour here, the length of their sleep episode, the principal determinant of the length of the sleep episode, was not how long they had been awake. Sometimes they were awake for 24 hours and they slept only 7 hours, and sometimes they were awake for 14 hours and they slept 14 hours. And so, to our surprise, the primary determinant was when they went to bed, and that determined how long they slept. So that if they went to bed here around 4, 5, 6 o'clock in the afternoon, in the evening, when the body temperature rhythm was near its highest, they would have tremendously long sleep episodes that would actually last, averaging about 16 hours. They would last until when their own body temperature was on the rising phase. In fact, 85% of all spontaneous awakenings occurred on this rising limb of the temperature cycle, when the brain is sending out its morning alarm clock or its drive for wakefulness. And if they went to bed shortly before that alarm clock went off, then even if they had been awake a long time, they slept a relatively short time. And when we discovered this, we realized that this had implications for shift workers and might account for why shift workers, when they were awake all day and then stayed up all night to work the night shift, they actually couldn't sleep as long when they went to bed in the morning. So here you see the going to bed at this phase, which I mentioned, which was associated with this very long sleep episodes, whereas going to bed at 6, 7 o'clock in the morning, 8 o'clock in the morning was associated with much shorter sleep episodes. And when we saw those results, I looked back at an earlier paper that had been done, that had been published a number of years before that, in which body temperature was again measured, but this was a very different protocol in which the participants were allowed to sleep 1 out of every 3 hours. And so they would have an hour that they could sleep, 2 hours of wakefulness, an hour that they could sleep, 2 hours of wakefulness. And this 3-hour, quote unquote, day, if you will, persisted. They were scheduled to this for 10 calendar days. And what you'll notice here is that even though these participants slept on average less than 4 hours per 24 hours over this 10-day interval, they still could not sleep more than 10 minutes of each available hour during the evening in what we will call, or what we have called, the wake maintenance zone. So this is the time near the crest of the body temperature cycle when it's very difficult for us to sleep. And that's why we call it this wake maintenance zone. So now if we look at these two findings together, they seem to show the opposite result. Because the longest sleep episodes, if you can fall asleep at or near this wake maintenance zone, typically in the late afternoon during that window where Professor Shea mentioned that people are running to get tea because there is a secondary increase in sleep propensity in the late afternoon. If individuals are able to fall asleep then, this is when they sleep all the way through this nadir of the body temperature cycle and wake up in this rising limb of the temperature cycle. So the longest sleep episodes are occurring when the sleep episodes begin near the wake maintenance zone. So it's not that the crest of the body temperature cycle is a time that we can sleep easily, but if we are able to get to sleep there, because we've been awake at least 14, 16 hours, and we are able to get to sleep, then we'll sleep a very long time, because the nadir of the body temperature cycle is when sleep propensity is greatest. But it's also precariously close to when the internal alarm clock goes off, which is why we can't sleep very long if we go to sleep near the nadir of the body temperature cycle. So this is kind of a paradoxical relationship and not what we expected. And we then began investigating this systematically by scheduling individuals to go to sleep at all different circadian phases. So instead of having them spontaneously decide, we scheduled them on non-24-hour day lengths, like in this case that's illustrated here in the slide on the left, in the figure on the left, which is called a raster plot. And it's kind of a difficult type of plot to follow, and I'm going to try to explain it. So the first day of the experiment is indicated in the upper left-hand panel. And then that data is plotted again on the right, because going from left to right is the first 48 hours of the study. The second day is also plotted underneath the first day, and the time is across the horizontal axis. So this is 6 o'clock in the morning, noon, 6 o'clock in the evening, and midnight. This is also midnight on the left here. So the participant began this study by going to bed at 1 or 1:30 in the morning every day, which was his habitual bedtime, and waking up about 8 hours later. Then on day 4, we scheduled him to go to bed 4 hours later, and then 4 hours later, and then 4 hours later, so that he was essentially living on a 28-hour day over the course of the next month. And so these are the first 3 scheduled nights, and then this is the 28-hour day that precesses through. And the open boxes reflect when the individual was scheduled to sleep. And the interruptions of those open boxes, this area that is filled in, is when the person was awake during the scheduled sleep episode. And you can see, and the horizontal bars here are when the hormone melatonin, which is a sleep-promoting hormone, is being released. So what you'll notice in this diagram is that the individual is, when they're scheduled to this 28-hour day, there are some times when they're able to sleep and maintain a consolidated bout of sleep, and that's when they are sleeping, when the sleep-promoting hormone and melatonin is being released. When they try to sleep during their biological daytime, that's when there is a lot of wakefulness that can be observed during the sleep episode. So here we have the melatonin rhythm that is precessing with a near 24-hour period, even though they're being scheduled on this 28-hour day. And we can average the sleep episodes under this condition, the percentage of time awake, the timing of the melatonin rhythm, and the time it takes to fall asleep. And what you can see here is that when we look at the melatonin rhythm, which is in the lower panel on the right, and we chart out the regular bedtime of the individual and the regular wake time of the individual prior to starting this experiment, we can see that when we schedule them to sleep during their biological daytime, between their wake time and their bedtime, there's a lot of time spent in wakefulness. In young people, that averages about 25% of the time. In older people, it's about 40 to 50% of the time that they'll be awake during their biological daytime on this kind of a schedule. You'll notice that the same individuals have no problem with insomnia when they're scheduled to sleep during their biological night. So this is the first problem for shift workers. And that is that when they're scheduled to sleep during the daytime, you might think, and some employers are of the opinion, well, we gave them 8 hours to sleep during the daytime, so they should be well rested. So whether you're talking about a truck driver or a factory worker, one has to account for the fact that the efficiency, the ability to sleep during the daytime is much lower for the average person than their ability to sleep at night. And so they're only going to be able to sleep about 6 hours and that's if they're young and healthy, if they attempt to sleep during 8 hours during the daytime, whereas they're asleep 93 or 95% of the time when they the same person is attempting to sleep at night when their melatonin is being released. Notice also that the propensity to be awake increases and keeps increasing and increasing throughout the day until it reaches a peak when it takes the longest time to fall asleep if we attempt to go to sleep. And that's this wake maintenance zone, which happens in the latter part of the day, in the several hours before we habitually go to sleep. This is the paradoxical part, because you would think that the brain is going to send out a stronger and stronger drive for sleep as the day wears on to enable us to fall asleep easily at night. But the circadian system, our internal clock, is sending out a stronger and stronger drive for wakefulness as our usual day progresses. And that helps to oppose the buildup of sleep pressure, which I'll get to in a moment, which increases with every hour of passing wakefulness. So the circadian system has this paradoxical timing. And what ends that wake maintenance zone is the timing of the release of melatonin, so which occurs typically an hour or two before our usual bedtime. And once that hormone is released, it quiets the output of the central circadian clock in the brain that is increasing the drive for wakefulness. And it quiets that output. The cells in that central clock stop firing, and we're able to go to sleep. And that's when the system is working optimally. And so sleep episodes begun at all different biological times of day, 6 o'clock in the morning, 6 o'clock in the evening. You'll notice that those that are begun in just after the wake maintenance zone, we can maintain consolidated sleep throughout the night. But if you try to go to bed like a shift worker at 7 or 8 o'clock in the morning, that's when you have to climb this mountain of wakefulness in the latter half of your sleep episode. Now, I alluded to the idea that there are actually two processes regulating sleep and wakefulness. One is the circadian clock, and the other is this sleep-dependent, or sometimes we call it a homeostatic process. And so the length of time in the sleep episode, if we have 8 hours or more in the sleep episode, you'll notice that the propensity to awaken becomes greater as the sleep episode continues. So as we dissipate, as we relieve the pressure for sleep by sleeping, then the tendency to wake up becomes greater and greater. And if we look at cognitive performance, with each passing hour of wakefulness, our performance deteriorates. And that reflects the increasing pressure to sleep. And we've analyzed these data, separating out the influence of circadian rhythms through some mathematical trickery. So you can see that all other things being equal, if we average across circadian phases, we see that alertness also decreases with each passing hour of wakefulness. But the reason that, and if we keep people awake continuously for more than 24 hours, what you can see here is that the story is not so simple if we are not able to separate out the influence of this internal clock in the brain, which I've illustrated just in the hypothalamus above the optic chiasm here. And what you can see here is if you keep someone continuously awake, they don't have a linear increase in sleepiness. But if we look at slow eye movements, which are characterized by an individual, and I'm hoping that doesn't happen during this 50-minute lecture, their eyes begin rolling around in their sockets. This is much more likely to happen near our habitual wake time at around 4, 5, 6, 7 o'clock in the morning, because that's when the drive for sleep emanating from the circadian system is greatest. We're least likely to have those episodes or to drop into sleep in the evening wake maintenance zone when the drive for sleep is the least. And right away, we can see an implication for night shift workers, because night shift workers who often are awake during the day before they even begin their shift, when we look at their self-reported sleepiness in the upper right-hand corner, or attentional failures where they're trying to stay awake, but the brain switches off and they have lapses of attention, you see that those are much, much more likely to happen as the night shift progresses, reaching a crescendo at the time that they would normally be driving home from work at 7, 8, 9 o'clock in the morning, which makes that a critical zone of vulnerability. And we can take these data and plot them three-dimensionally. So we have the time of day on the horizontal axis. We have the length of time that they're awake as sleep pressure is building up. And then we have the percentage of time that their eyes are rolling around in their sockets, exhibiting slow eye movements. And that's what's shown in the left-hand panel. And what you can see is that even if you've been awake for 26 hours, if you are attempting to stay awake during the wake maintenance zone, this little trough here in the evening, you can sustain wakefulness at that time. And it's kind of one of the things that drives our epidemic of sleep deficiency, because you may be exhausted in the morning when you wake up because you're very close to the peak of the circadian rhythm of sleep propensity. But by the time you're making a decision as to whether or not you're going to go to sleep at night, you've got this second wind that is being driven by this wake maintenance zone, and you've forgotten about how tired you were in the morning, how much caffeine you had to take in the morning, because you're feeling alert. On the other hand, if you're working the night shift, and some night shift workers call this hitting the wall, at a time when they've been awake at least 14 hours, and they're trying to function at the nadir of the body temperature cycle. There's no second wind rescuing them there. In fact, it's quite the opposite. The drive for sleep is the greatest at that time. Then it's very difficult to sustain wakefulness and prevent yourself from experiencing errors or accidents. The same impact describes our ability to sustain wakefulness, and I'll go through this a bit later with a couple of other slides, but you can see that the ability to maintain consolidated sleep also varies with circadian phase and the length of time in the sleep episode. And we can sustain sleep if we go to bed during this one very narrow window. But if we go to bed in the morning, then we're going to have to climb this mountain of wakefulness. Now, that impact in the critical zone of vulnerability in the morning, I've tamped down the slides that I just showed you a moment ago by changing the scaling on this so that individuals who are spending a third of the time attempting to sleep are in the lower panel, 8 hours of sleep per 24 hours. We've also done experiments with individuals who are only scheduled to sleep 5 to 6 hours per 24 hours. And when you combine chronic sleep deficiency with misalignment of circadian phase, then the risk after 3 weeks of doing this is week 1, week 2, and week 3, the risk of an attentional failure is 10 times higher when you're at that adverse circadian phase. And unfortunately, that's the experience that many night shift workers have. Truck drivers, on average, who are driving at night and attempting to sleep during the day, only get about 4 to 5 hours of sleep every day, and then they're driving 80,000-pound vehicles during the nighttime. So you see how that can lead to a critical zone of vulnerability that's even greater when they are chronically sleep deprived. Just to show you how powerful the wake maintenance zone is, however, you can see that even if an individual is kept awake for 2 consecutive nights, as is shown on the right-hand panel of this graphic, their performance on the psychomotor vigilance task, although it declines during the critical zone of vulnerability during the nighttime, it then, without any subsequent sleep, the performance improves during the evening wake maintenance zone before deteriorating thereafter. So, wake propensity and the ability to remain awake vary with circadian phase, including the wake maintenance zone and the critical zone of vulnerability. So, what I've tried to review here is that sleep and wakefulness are regulated by 2 primarily biological processes, this homeostatic process and the circadian process that interact to optimize sleep and wakefulness during entrainment. And the interaction in terms of the consolidated sleep means that we can consolidate sleep when we go to bed at an optimal phase, when it's initiated during the biological night, whereas poor sleep occurs and it's disrupted when we initiate sleep during the biological day. Now, I want to just take a moment, because this has been, conveying this information has always been a challenge, because it's a complex story that I've just told. And Steve Shea, when he was here at the Harvard Medical School, agreed to take on the task of trying to convey this in a straightforward way as part of our sleep and health education program. And this graphic can still be seen on our website, understandingsleep.org. And what Steve illustrated in this beautiful sequence of diagrams is that there's an increase, is the interaction between these 2 processes, with increasing sleep drive that occurs during the daytime and the decreasing sleep drive that occurs during the nighttime when we sleep, and how that interacts with the circadian process, which is providing this alerting signal that peaks at the end of the evening. And these 2 processes interact so that we can maintain a stable level of alertness throughout the day, because the increasing sleep drive is being opposed by the alerting signal that normally occurs during the daytime. And then when we go to sleep at night, the sleep drive is dissipating because we are sleeping. The alerting signal is reducing. And so if we're getting enough sleep on a regular basis, we'll be able to awaken refreshed, because even though we're very near the point at which we have the strongest drive for sleep emanating from the circadian system, we have dissipated that sleep drive by having gotten a good night's sleep the night before. Now, the problem is that humans have decided that they're going to be awake at all different times of day and night, and we have the technology to allow us to do so. We have people working at night. A quarter of the population has some sort of non-standard work schedule. And when that happens, and again, Professor Shea did a beautiful job of illustrating this, when shift work intervenes, you may be beginning your sleep episode after a full day of wakefulness, beginning your work shift. And when that happens, your work shift is now beginning at a time that your sleep drive is going to be increasing throughout the night shift. And so you don't have any rescue here, but your sleep drive is continuing to build up sleep propensity. And that's going to result in this critical zone of vulnerability. And then when you get to the second day of night shift work, now you're attempting to sleep during the day. It's not going to be as effective because your sleep efficiency is going to be degraded. And then when you go to sleep the next night, you're now, your alertness is lower because you haven't gotten an adequate amount of sleep, and staying awake on the job just becomes a constant struggle. I want to thank I want to thank Professor Shea for these illustrations, which I think help make this point very powerfully. Now, one of the questions that I'm frequently asked is, aren't there individual differences in the performance vulnerability to sleep deprivation? And the short answer is yes. There's a huge difference between those individuals, and we can identify them from a 10-minute task that we developed these metrics with DARPA when we had a project working on them, on that with Josh Gooley and Gene Duffy and others here at the lab. And we're able to classify people. Amazingly, those in green are those classified as resilient. Those in blue are those classified, those in blue are those classified as resilient, and those in green are those we classified in this 10-minute test taken during the daytime as vulnerable. They rate themselves exactly the same. So the self-rating of sleepiness during the night shift is the same in both cases. But when we look at the number of attentional failures, you see that those who we have identified as being vulnerable have a huge number of attentional failures during the nighttime. And those on the first night shift who have been classified as resilient have very few attentional failures. And we can classify them with a great degree of precision. Of course, if they stay awake a second night or continue to be chronically sleep deprived, then even those who are resilient will begin to exhibit adverse effects. But that's one of the reasons why we can't, you may have somebody doing the scheduling who happens to be resilient and can't understand why other people are having trouble. And we have to recognize that there are inter-individual differences in our ability to sustain these types of schedules. And we can't have the tyranny of the people scheduling individuals, scheduling those who are particularly vulnerable to work schedules to which they can't adapt. This sort of opens up the discussion to shift work disorder, which is characterized by complaints of insomnia during the daytime, sleep of night shift workers, or excessive sleepiness during night work in hours that are scheduled during the usual sleep episodes. This can occur in people having early morning start times between 4 and 7 in the morning, as well as who are staying awake all night. Drowsy driving accidents risks are highest in the morning hours. When we have studied people after on a closed track where we can safely evaluate them, we found that the risk of a near crash incident is astounding and occurred in more than a third of individuals scheduled to drive after having worked all night. Whereas those same individuals scheduled to drive at the same time when they haven't worked all night, you can't even see the data because it's the black line right on the zero level, because we didn't see any near crash incidents during these driving sessions that were scheduled after the post-sleep drive. And it's not just the near crash incidents where they were running off of the road and the person with the second set of controls in the car, thankfully, had to slam on the brakes. But it could be detected much earlier than that with lane crossings, difficulty keeping to the middle of the road, and struggling to keep their eyes open. So the impairment of driving is one of the most serious things. I was delighted to see that Professor Shea mentioned this study that I did a number of years ago, right after we recognized that shift work schedules, right after we recognized that the circadian system was one of the primary drivers of the ability to sleep. We then applied that. First, we tried to change the work schedule gradually, like the people did in the lab. And Steve is correct that the plant manager said, we don't cut off a dog's tail an inch at a time. So then we shifted the schedule. We adapted. We changed the plan. and we had them maintain a steady work schedule for 3 weeks at a time before abruptly shifting to the next shift. So they went from day shift, and we also changed the direction of shift rotation. So they went from day shift to evening shift and evening shift to night shift, instead of trying to go in a counterclockwise direction, which is the opposite of the natural tendency of the circadian system in most people, to drift to a later hour. And what we found was, among a number of improvements in work schedule satisfaction, subjective health estimates, and personnel turnover, there was also a significant improvement of about 20% in the productivity measures in terms of tons per truck hour that were being harvested and being processed at the plant. So that was an intervention in which we worked on the design of the work schedule and tried to make it more compatible with how the circadian system works. We've also done interventions in the healthcare sector of work schedules where we looked at the scheduling of the duration of work. So now this is primarily targeting the homeostatic system instead of the circadian system, like in the other intervention that I mentioned. And we identified that 1 out of 5 resident physicians admitted to making a fatigue-related mistake that injured a patient when they worked 24-hour shifts. And 1 out of 20 admitted to making a mistake that resulted in the death of a patient, and that was increased 300% when they worked at least 5 24-hour shifts in a month-long period. We published a series of papers on the risks of extended duration work shifts that were being practiced in medicine on a routine basis on medical trainees. And we found that they had many more attentional failures at night, made more serious medical errors, including more than 400% increase in serious diagnostic mistakes. They had more than double the risk of crashing on their way home from work in the morning, and had a much greater risk of stabbing themselves with needles or scalpels when they were working with patients. And even experienced surgeons had 170% increased risk of complications in patients undergoing elective surgery in the morning if the attending surgeon had had less than a 6-hour opportunity for sleep during the prior night on call. Then we did an intervention in which we reduced the duration of the work shifts to a maximum of 16 hours, and we found that the risk of an attentional failure dropped in half. So this was one of our second major intervention studies. We then, that was in an individual center. We then did a study across 6 different medical centers around the United States. And we found that something interesting happened when we reduced the duration of the shifts to 16 hours, unlike our single center study, where we made sure that we added an extra resident physician. When we rolled this out across the country, many academic medical centers did not have the staff available to do that, and so workload increased. And this reminds me of the sort of the I Love Lucy episode where she was packaging chocolates, and if they made the conveyor belt go faster and faster, eventually she was stuffing chocolates everywhere, eating chocolates, because she could not keep up. She could not do a good job. And when the number of intensive care unit patients per resident physician exceeds about 7, then when we reduce the work schedule, when we reduce the number of work hours and the number of patients per resident physician, the workload went up. That actually resulted in an increased risk of error. So we can't reduce work hours at the expense of increasing workload. You know, we had a 75% reduction in the risk of errors if the work hours, the extended duration shifts, were eliminated while keeping the workload at a reasonable level. But the errors actually increased if workload increased. So the sort of take-home message is that there are other factors besides the work schedule, the most prominent of which we see is workload, that can impact the risk of serious medical errors. And if we, and the bottom line for this is if we do it well and reasonably without increasing workload, then we can have a 50% reduction in serious medical errors by eliminating those extended duration work shifts. And this is consistent with data that's been gathered now nationwide on the impact of the limitations on resident physician work hours that have resulted in a decrease in needle stick injuries, a decrease in near crashes, a decrease in motor vehicle crashes and attentional failures, and a decrease in both fatal and non-fatal medical errors. So these kinds of data have resulted in some policy implementations, one of which is in the European Union, the regulation that individuals can't be scheduled to work more than 11 hours in any 24 hours. So they have a guarantee, if they wish to exercise this right, of at least 13 hours off every day. And it provides for the right to work no more than 48 hours per week. We don't have any such legislation in the United States, but I'm pleased to report that even though the Accreditation Council for Graduate Medical Education has lifted the limitations that they imposed after our studies were initially published, and now training programs can again schedule resident physicians to work nearly 30-hour shifts. We found when we have looked at the actual percentage of individuals who are working those extended duration shifts that they've decreased massively. So instead of 68% of the individuals being scheduled to those schedules and 90% when they're in ICU rotations, that has gone down by a factor of nearly 10, even though those programs have lifted. So the limitations have been lifted. So there has been a change in the culture, I think, as a result of people understanding the risks associated with these extended duration shifts, so that even though they're now permitted, unfortunately, in the United States, they're not being practiced nearly as often. Now, the next thing I want to talk about is, so we've talked about countermeasures. One of them is policies, work schedule design, and implementation of policies that can reduce the risk of taxing the homeostatic or the circadian system. But now, what if we could shift the circadian system and make it easier to work at night? So in the late 1980s, we discovered that light is the most powerful means of resetting the human circadian pacemaker, and that we could reset within about 3 days by up to 12 hours the timing of our biological clock. So the first thing that we wanted to do was to see, could we enable people to adapt to night work, which most of the time people do not. And so on the left here, you see the body temperature rhythm of individuals on the first night shift and on the sixth night shift. And you can see that after a week of working at night, the circadian system is not adapted. When we applied what we had learned from the resetting effects of light, you can see that exposure to light at night completely reset the circadian system so that the individuals could be just as alert working during the nighttime as they were during the daytime. And you can see that the rhythm of alertness, body temperature, cognitive performance, etc., are all shifted. They're sleeping 2 hours more when they're sleeping during the daytime because their circadian rhythms have completely adapted to a schedule of night night work and day sleep. So that was exciting to us, that we could achieve, and we repeated this in larger samples. And the first place we applied this was to the astronauts who said, we want to be able to launch our space shuttle at night. Can you help facilitate our adaptation to that type of schedule? We exposed them to light at night. You can see how well adapted they were. And they're releasing them melatonin during their daytime sleep instead of during their waking night. It's fun working with the astronauts. On this project, we then did simulations in the laboratory and showed that whichever way they needed to shift, we could, whereas on the control, they were not able to adapt the timing of their melatonin release. With light treatment, we were able to shift their circadian rhythms. And we even began to then apply this in factories where people were working at night. This happens to be San Diego Gas and Electric. We've also relamped, we redesigned the lighting with Steve Lockley and Bob Brainerd and Beth Clareman on the International Space Station. When their fluorescent lamps began to burn out, they needed to install new ones. And because we know that the wavelength of light is also a critically important factor, we got them to install lamps that could allow us to address both the duration, the timing, and the intensity and the wavelength of the light. So that's another countermeasure that can be deployed. But it's not always possible. Let's say you're a policeman and you're working at night. You can't bring with you an entire facility that changes your exposure to light at night. So how else can we help people to sleep during the day, which is one of the major challenges of shift work disorder, and to stay awake at night? And so giving a compound like, we thought, well, what about if we try giving people melatonin? They're not releasing it during the day. Can we give it to them during the day? And we did find that that can enhance their sleep, daytime sleep. With just 0.3 milligrams of melatonin taken during the daytime, they get about a half an hour, 45 minutes more sleep. We also tried giving them a patch, and this is the work of Daniel Esbach and colleagues. And you see when we give them a patch, they have more melatonin that kind of replicates the pattern of melatonin that they would having at night. And then they got more sleep. Their sleep efficiency improved. Instead of waking up in the latter half of the night, they were able to stay more asleep. And had a significant improvement in the number of minutes that they were awake after sleep onset. Another drug that can be used is caffeine. We had kind of a novel administration plan for the caffeine, because we realized that taking a huge bolus of caffeine at the beginning of your night shift when you're in the wake maintenance zone is not a great strategy, because it's going to be dissipating as the night wears on when you need it. And so we gave very small amounts, like just a little sip of designer coffee, but was in a tablet, every hour, so that the caffeine levels were rising, but not getting too high, but rising as the night wore on. And you can see that we can knock down that critical zone of vulnerability. Instead of being huge, we can knock it down so that it is much more manageable and yet doesn't have the likelihood of interfering as much with their daytime sleep, which they need to initiate shortly after. These were registration trials for modafinil and armodafinil that I mentioned earlier, which we have also worked on developing for treatment of excessive sleepiness associated with night shift work. And here you can see that their sleepiness, as measured by the multiple sleep latency test, taking modafinil was much less, and their attentional failures were much less on modafinil than they were on placebo. And armodafinil, which lasts longer, then allows them to sustain throughout the night instead of losing effectiveness in the latter half of the night to be more effective. So if we sort of take stock now, we've talked about the number of hours awake, homeostatic regulation. We've talked about the accumulation of sleep debt, when the amount of sleep that you're getting is not as much as the amount of sleep that you need, that can accumulate sleep debt. We haven't talked about another factor that causes fatigue, which are sleep disorders. And that's what I'm going to talk about next. So sleep disorders, there are about 85 of them, but we have focused on primarily obstructive sleep apnea, shift work disorder, insomnia disorder. I'm really going to talk about mainly obstructive sleep apnea for a few minutes. I commend you to look at this site, which Stuart Kwan and Steve Shea and others developed at understandingsleep.org. You can see a funny video with Shaq talking about sleep apnea. I'm not going to really go into it, except for to say that it's a serious sleep disorder that, besides its effects on alertness and so on, can really decrease the lifespan of individuals who substantially who are not treated because it increases the risk of cardiovascular death by 300 or 400%. But what I'm really focused on here is the impact on the ability to function effectively working at night. So we found, looking at police, firefighters, and healthcare workers, that a substantial fraction of them have a high risk for at least one of these common sleep disorders, whether it be obstructive sleep apnea, which is the most common in police and firefighters, and then in healthcare workers where there are more women, it is shift work disorder and insomnia that are more common. But about a third or more of shift workers, night shift workers, suffer from one or more of these disorders. We did a study of police officers, about 5,000 of them around the country. This is the work of Shantha Rajaratnam and others in our group. And as I mentioned, we found that 1 out of 3 of them had screened positive for sleep apnea, and sleep apnea was associated with increased risk of falling asleep while driving, safety violations, occupational injuries, cardiovascular disease, diabetes, and other adverse health effects, both health, safety, and including physical and mental health. One of the tools that we have used to try to address this is a combination of sleep health education and sleep disorder screening. And this is an example of a sleep health education program that we have, and that sleep health education we developed for the railroad, for the National Rail Association, and it's available at railroadersleep.org. But sleep health education is critical, especially if you're going to do sleep disorder screening, because people need to understand why it's important to get screened for a sleep disorder and why it's important to have that disorder treated. And when we combine sleep health education and sleep disorder screening, particularly among people who need to work at night, and this happens to be firefighters who often work 24 or 48-hour shifts, and it's embedded in the culture, just like in medicine, very difficult to change. And many people gave up on this population, saying, there's nothing we can do to help them sleep because they're scheduled to work such enormous hours. We said, what if we tackle the high prevalence of sleep disorders in this population, in particular obstructive sleep apnea? And we found that an hour-long sleep health education and sleep disorder screening program was able to have substantial improvements, 24% over a year follow-up period in a randomized design, 24% fewer injuries among the firefighters, a 46% reduction in disability day usage, which you see illustrated in the right-hand panel, which the department in Columbus said saved them $2.2 million a year. And in studies among truck drivers, a 5-fold higher rate of serious preventable crashes among truck drivers who were diagnosed with sleep apnea, who were not compliant with treatment, and a $3,000 per year cost savings in healthcare costs for truck drivers who were compliant with sleep apnea treatment. And so, I think that because we know that chronic sleep deficiency interacts badly with acute sleep deprivation in night shift work, that's why we decided, we need to approach bad sleep quality so that we can reduce the risk of chronic sleep deficiency among those attempting to work at night, because those are the people who are trying to protect us, who are trying to help maintain 24/7 operations, and we need to do everything that we can to help support them. So the components of a comprehensive fatigue risk management program in safety-sensitive industry, I think, includes an education program, work scheduling policies that are grounded on sleep and circadian science, monitoring the effectiveness of those policies and whether or not they're being implemented, mandatory screening for sleep disorders of all employees, specifically including obstructive sleep apnea, at home, ideally, objective testing for sleep apnea, particularly in those who are overweight and obese, and who are at highest risk for sleep apnea. And then ensuring that those who are diagnosed with sleep apnea are compliant with treatment and that the treatment is effective at reducing their increased sleep tendency during their work schedule. We've been working very hard at the Brigham and Women's Hospital to develop a Sleep Matters Initiative program to help roll out these initiatives to those who need them. And I'm very pleased to have been able to share this with you. And I'm kind of stunned that I'm only 1 minute over, since I was Steve had asked me to review all these different areas. So thank you very much for your attention.
Chuck, I have to say that was fantastic. You had me worried for a minute when you were 7 minutes on the first slide and you had 77 slides to go. It was fantastic. We do have some time for questions, and there's some people raising their hands, so we're going to come to them. But I was so impressed with that you actually did fit it all in, all about the timing of sleep, the importance of the amount of sleep, the interaction of the sleep and circadian system, interventions to improve sleep in terms of light, melatonin, coffee, coffees to improve wakefulness and performance, and modafinil, and also touched on the work hours regulations and policies, which are also important, plus of course, the importance of screening for sleep disorders, which is a parallel concern for many people who work nights and will just exacerbate things. And then you talked a lot about the win-win situation of if you get your sleep disorders treated, and if you have the policies in place, and if you have some of the interventions at your fingertips, then you can help the health and vigilance and well-being, presumably, of the workers, plus the productivity of the worker, and reduce accidents, which also helps both the worker and the company. So, and then you talked about sleep education on this lovely website. So I thought that was absolutely wonderful. I'm going to open it up now for a few questions. So whoever put their hands up, I can't see. Can I have some help from the organizers? How do we, whoever put their hands up, maybe you could activate your camera and unmute yourself and ask the question, please.
Steve, this is Amy. We don't have any hands up at this moment. When we do, we'll unmute your camera, or we'll unmute your voice and camera. Okay,
so I saw some hands, it said to me that hands were going up, but maybe they put their hands down. If there are any questions, yes, please feel free to unmute yourself and ask those questions, and even activate your video if you wish.
Professor Czeisler, thank you for a wonderful presentation. My name is Sean McGillis. I work with the Institute. Thank you again for joining us today. I do have a question for you. Can you share with the group where you think this work is going forward into the future, and what that means for our understanding of shift work and health overall?
Yes, one of the things that I think is an exciting new area that is being developed is, first of all, the integration of all of this information. So we basically, over the course of the time that we've been working on this, we and others have worked on sort of one element of this complex situation at a time. But now it's possible to integrate all of these elements together to help personalize for an individual, because I've talked about averages, but we know, for example, that women have a shorter intrinsic period of the circadian system than men, and that their vulnerability is different at different phases of the menstrual cycle. And at one phase of the menstrual cycle, they are less vulnerable than men. At another phase of the menstrual cycle, they're more vulnerable. And so countermeasures really need to be deployed that are tailored to the individual. And integrating all the different kinds of work, and we've been working on this steadily throughout this time, developing mathematical models and so on to help summarize the information and allow us to make predictions. But now incorporation of interventions and countermeasures to help facilitate adaptation to night shift workers on a more individual basis rather than trying to do it on a group basis, I think is an exciting new direction. And I think the other exciting time is that there's so much more awareness of the importance of this for both health and safety that I see a moment in our society where we can begin to adopt more reasonable policies. And just like, now we're seeing headway on other fronts in terms of school start times. So the state of California and now the state of Florida and other states are moving school start times to a later hour, something that it took 4 years to do it in California. It's taken only 2 weeks recently to get legislation passed and signed by the governor of Florida to get that done. So I think as awareness of the importance of these issues grows, then I think both public policy, individual company policy. I mean, the Rand Corporation did a very interesting study in which they said that the U.S. economy it's costing $400 billion associated with the problems associated with sleep deficiency and circadian misalignment. Companies are beginning to recognize, and we've developed a fatigue cost calculator that integrates all of the world literature on this topic and says, if you have a company with this size, and this is what it's costing you, and this is what you might gain by implementing some of these measures. And so I think we're at sort of the next stage where we can actually seize the situation and begin to implement this on an individual workplace by individual workplace basis, and result in real improvements in health, safety, and productivity.
Thank you.
Hi there. Hi there, this is Susan. I actually have 2 questions for you. I love what you said about a tyranny resilient scheduler. I thought that was really important to note, and I will follow up with our sleep program to see if our scheduler for studies is opposed to or is resilient in that aspect. I thought that was pretty great. Have you done any policy reviews of healthcare organizations or academic medical organizations on policies and scheduling policies for their third shift workers? And have you found if healthcare centers or anyone else, call centers, 911 centers, this is research that has been proven, I think, for many years now, that they're actually implementing training and that policies to help with not scheduling people or being flexible with people that aren't as resilient for night after night, third shift?
That's a great question. I haven't seen, one of the things that we thought this would be a great tool for would be having people, get career advice as to what type of career to go into, or the military could use it to decide or to help select people for special forces assignments, where they really need to make sure that individuals are able to remain alert and awake during the nighttime hours. But especially since you can't rely on self-report. But I don't know of any institutions that have implemented this, even though we've published the process and written a couple of papers about it. But I think that that's another way of personalizing it, because if you had this information on an individual, then the two things you could do, one would be sort of career advice, but the second would be deployment of countermeasures. So you would know that an individual who was more vulnerable would maybe need to deploy countermeasures like the small frequent doses of caffeine or the use of some other approved compound for helping them either sleep during the daytime or remain vigilant and awake at night. So that's what I meant by the personalization. This would be one of the elements of that personalization.
Okay, thank you. If there are no other hands up, I do have a question about your concern about
Susan,
the overdosing of.
Susan,
Yeah.
can I interrupt you for just one moment, because there is one more question and I want to make sure we give time to Momiko, who's been trying to ask a question. Do you mind?
Oh, not at all.
Okay, and then maybe we can go to you, Leslie.
Dr. Czeisler, thank you so much. It's really fantastic. I am an applied workplace researcher, and I have done a little bit of work with the help of Dr. Shea and others, developing training for managers and supervisors in the military and in the non-military setting around sleep leadership, and really touching on basically teaching leaders in a very concise way about the importance of sleep and how to support the sleep health of their employees, but nothing detailed and as specific in terms of all of the critical information that managers and supervisors should have to really understand the profound effect of sleep on work. And I think that would take a much more in-depth training than what I've done, which is a succinct 1-hour training. It's helpful, and we actually see positive effects on sleep outcomes, which is great. But I'm wondering, are you aware of any longer, more intensive and effective manager, supervisor trainings around really the critical importance of sleep and the outcomes associated in the workplace, and just so that they can get more motivated to really work and change the workplace culture and change the design of work to respond to these issues? Because from my perspective, it's much more of an organization. When you talk about workplaces, the organization really needs to take the responsibility of adapting as much as possible. So I'm just wondering where we are with all of this in the workplace.
I think in the workplace, we really are at the beginning, because while you have some programs and the military has deployed some other programs and educational materials, I don't see it at the present time. There are some companies like Snyder Trucking, J.B. Hunt, that have implemented really comprehensive programs for screening for obstructive sleep apnea, for example. And they've made a commitment. And they've also introduced other programs, for example, at Snyder Trucking. They recognize that the risk of an attentional failure is greatest at night, and that they are driving at night. Therefore, they made an investment to equip all of their trucks with collision avoidance systems where the truck will intervene and apply the brakes if the driver is driving toward another vehicle and is not stopping. So there are various technological and medical solutions that are being implemented by individual employers. And that, by the way, that collision avoidance reduced, I think, 90 or 95% of their of such crashes. So I think if companies and employers are intentional and really set aside the resources to make sure that the training and education happens, that the everywhere from the C-suite down to the people scheduling individuals are committed to doing a good job at this, and that they have input from professionals who can advise them on the importance of these issues and how to deploy these countermeasures, then I think we can make it. That's the next frontier to do this, on as many organizations as possible. And when I'm teaching the undergraduate courses at the university, I try to ensure that all of the students taking the course will make a commitment that when they go off to run companies and so on, that they'll try to implement these policies in their workplace. And they're all enthusiastic, at least as undergraduates, that they will do so. So we'll see how long it takes to get this culture to change.
So we're going to move on to the next session now. Professor Czeisler's presentation talked a lot about theory, but also practice in some workforces where they have to stay awake at night, such as police, firefighters, healthcare, residents, resident physicians, etc. And now that we're going to open up a panel of two of those industries or workforces. First, we have Michael Whitaker, who is currently a director of adult critical care services at OHSU and oversees 5 critical care nursing teams and several clinical programs such as stroke, ECMO, and virtual ICU. Michael's worked as a critical care nurse since 2009, and it's included many night shifts, and he's been a nurse manager at the ICU at OHSU for 5 years, and then took over a director role for critical care services. In his work as a nursing leader, he focuses on patient safety, evidence-based nursing practice, empowerment of nurses at OHSU, and seeks to provide a safe work environment for all staff. So, Michael, are you there? Yes, I can see you. Yeah.
Hi, everyone. Thanks for.
Hi. I'm going to introduce the next panelist in a moment, but Michael, did I miss anything out that's important about your background so that the audience should know about you?
No, that's touched on all the points there. It's been a while since I've been a night shift employee, but certainly I've been managing night shift employees for quite some time now. So excited to be here. So
we're going to go through some questions from me to everybody, and Professor Czeisler remained online for this panel discussion as well. The next person is Neil Parker. Neil Parker is a police officer and wellness program coordinator at the Portland Police Bureau. Neil's been there with the Portland Police Bureau since 2008 and spent the first 10 years serving the community in Northeast Portland on night shift in the North Precinct, and then moved on to day shift, possibly as a preference, I don't know. And for the last 3 years, he's been one of the lead patrol procedures instructors. In that role, Neil was responsible for developing and facilitating realistic scenario-based training that develops officers' ability to critically think in through complex situations. In May of 2023, so just last month, Neil became the wellness program coordinator for the Portland Police Bureau based on his experience in developing and instructing wellness classes And outside of his police bureau work, Neil's a member of the Oregon Air National Guard since 2004, and has been deployed in service operations Enduring Freedom and Operation Iraqi Freedom. So Neil has endured a lot of night work and has been helping the police deal with that night work situation in terms of health. So Neil, is there anything else you'd like to add about your background before we start with some questions?
No, that was great. Just happy to be here. Thank you guys very much.
Yeah, thanks to all the panelists. So as I mentioned in the chat, if any of the audience wants to add any questions to these panelists, please, it's probably best if you put it in the chat because we may be able to answer the questions online as we go. But if not, we can. Hopefully, there'll be time for you to speak at the end of this discussion. So you all work in well, Neil and Michael work in industries that respond to emergency situations, and your staff need to be available around the clock, and often need to recover from a sleepless night. So, can I start with you, Michael? Can you tell us a little bit about what's unique in your specific position? And go ahead.
Yes, definitely. So what's unique about the ICU environment at OHSU and probably most other institutions is just the 24-hour, 7-day-a-week operating model. So at any point on any given day or night, in this case, we have nurses working around the clock to ensure patient care is being implemented. There's a wide array of stakeholders that engage in that patient care, and so you need your faculties about you to move through your shift and engage with the various stakeholders and to provide critical care, nursing interventions, and medical interventions to patients. And so you're doing that overnight in a stressful environment, and there are certainly ebbs and flows to it, but the 24-hour, 7-day-a-week nature definitely makes it hard to maintain readiness. And as we all know, the healthcare industry has been challenged for many years, but certainly coming through the pandemic and dealing with the aftermath, our staffing is low, and so it adds greater pressure to the environment that we're trying to provide to enact that patient care.
And can I ask you, I know that there's been a critical shortage of nurses in recent past, and I know that in firefighters there's been sort of mandatory overtime. And this points to one of the questions that Judith asked earlier, which was, are there any, well, she was asking Professor Czeisler, are there any studies on diminishing returns on a night shift, meaning that if you go for 8 hours, 10 hours, 12 hours, now, you know, it might be necessary in some cases, but it may be counterproductive to have somebody so tired at working for very long shifts. So I'm going to ask you, Michael, to reflect on that, and I'll also ask the same of Chuck Czeisler in a moment from a theoretical basis. Mike?
Yes. So nursing is pretty standard where we use a 12.5-hour shift in the hospital setting. And I believe that came about before my time as a nurse in the 70s and 80s. It became pretty standard. It's been that way since then. And I am not aware of any data that would suggest that that is better for the nurse or the patient, but it was developed as a patient continuity approach. So I do think that the 12-hour work shift is definitely something that needs to be studied in relation to patient care and the nurse's effectiveness across those 12 hours. The challenge becomes, it's been such a selling point, I would say, for the profession. Nurses really love their 3 12-hour shifts, and to move away from that would be very difficult. It would take a cultural sea change to really implement the science behind sleep and move away from that 12-hour shift. So that would be a challenge, and certainly something that needs to be a cultural change.
Right. So so that's very interesting that people like to work the long shifts, partly, I presume, because they get more consecutive days off. And Professor Czeisler, do you have any comments on this topic of potentially underperforming at work, or putting yourself at danger, or putting yourself at risk for long-term health problems based on disturbed sleep and etc. But having having a better home life because you have more time off?
Yes, it was. It's a very interesting topic because when we did those studies that you mentioned in your introduction about the work schedules that could be improved by applying circadian principles, that sort of spawned a whole consulting initiative with many different firms going around the country, working with factories. We had over 1,000 inquiries from factories and other workplaces. That was kind of overwhelming after we published that article. And you can imagine that these kinds of changes there had to be close work between the employees, sometimes represented by unions, and management, and the operational needs of the facility. And one of the things that emerged within about a decade of that was that in walking that tightrope, if you could dangle the possibility of getting 2 extra days off per week to the employees, you could easily get them to buy in, even though that all the evidence indicated that that was not good from because it increases the homeostatic drive for sleep. You're taking individuals working the night shift and they're having difficulty enough working 8 hours. You're now extending that to 12 hours. And there are a number of studies showing that errors increase and risk increases and so on. But it was very easy to get sort of a consulting win by going in, implementing a 12-hour shift. The employees think it's great. There's less commuting time. There's, as you say, more time with your family and so on. And it became very common in many industries, including nursing. Anne Rothgeb did a number of studies, and she's at Emory University, on nurses. And we also studied nurses. I wasn't able to include those data today, just because of time, showing that the Anne's data shows pretty convincingly that as you increase from 8 hours, and particularly if you go over 12, and one of the problems with having the nominal shift of 12 hours is then if the next nurse for some reason doesn't show up or is sick or whatever, now you start to have, ideally not, but now you start to have the possibility of having even longer shifts, or people having to take overtime. So now they're working instead of 3 shifts a week, maybe 4 or even 5 shifts a week, and fatigue really builds up more and more when you don't have an adequate amount of time to sleep, which when you're working 12 hours a day, most people are getting an insufficient amount of sleep just because they don't have time to sleep. So on their time off. So I think 12-hour shifts are problematic. I mean, they're better than 24-hour shifts, but ideally shifts at night would be, if we think of the average 8-hour day worker is exhausted when they finish 8 hours at work, you can imagine working an overnight shift and facing 12 hours instead of 8.
Yeah. Yeah. Well, thank you for that. I know there must be a smile on some of the faces of some of the people in the room. I'm thinking of Travis Chipman and Cameron Homan, who are firefighters who have some shifts that last 48 hours. And Nicole Bowles and those 2 individuals are going to be talking this afternoon, so we'll extend that conversation there. I'd like to move on to ask Neil now, representing the police, what is unique about your specific profession, and in terms of specifically about keeping people alert and awake for long shifts and across the night.
Yeah, so thank you for the question. I don't know if it's unique to our industry, but how our shifts are built. We work in a 4-10 schedule, at least here. And like others have said, it would be hard to move our people away from that at this point. I think they like their 10-hour shifts for the reasons that I believe you mentioned, the additional, day off potentially for their weekend. But some uniqueness for us, or at least some challenges for us, are similar to what, the nurses and firefighters talked about, is as our shifts, grow longer and get, into their waning hours, it's generally when, we're starting to get down to like paper, filling out the paperwork and kind of using our memory and all our faculties to document, the events of the shift as it happened throughout the night. And, after 10 hours or once we're doing that, that's a mandatory thing for us. We have to get that done before the end of the shift. So then maybe that takes our 10-hour shift into the 11, 12, 13-hour time frame. And so now you're asking someone to write, as factual as they can, report a narrative of the events that happened. We see that becomes difficult, 1 or 2 years later down the road, when we're sitting at a trial for maybe one of those events, going back and looking at your report to refresh your memory. It's you start to notice all the errors, not they're more grammatical, but still you start to see the effect that maybe that had on you on a night shift. Some other things is, I think one of the leading causes of injury and death in policing is traffic accidents. And if you can imagine trying to, I think Dr. Czeisler was mentioning those hours between 4 and 7 a.m. We have our night shifters who are, their office is their car. And as they're driving around all night responding call to call to call, that 4 to 7 hours time frame can be very difficult to ask someone, to continue to be as alert as they were maybe at the beginning of their shift. Our night shifters tend to work a 10 p.m. to 8 a.m. shift. And so when I work night shift, I do recall the 4 a.m. hour, no matter how many years I had been doing it, really was hard for me to adapt to. It was the time when I felt my lowest, the lowest amount of energy if I wasn't doing anything. If I was on a call, I felt okay. So yeah, just the nature that we don't have really a place that all our officers come from. We're not coming from the police station. We're usually in our cars, out in our districts. And so we're oftentimes in that car driving around for 8 to 10 hours. And so, that one of the things that has come of that is the highest percentage of officer injury and death has become traffic accidents. And I'd imagine that fatigue plays a big role in that.
Yeah. Thank you. So Neil, following on from that, so you say, of course, the police officer's office is sometimes, mostly during the night, maybe their vehicle, and then they stop work. And do people often stop, after a night shift, and then they have to drive home? So do you see that as an issue that, in terms of you, a wellness officer, you must be concerned about that for your staff, and that, incorporating the commute home? Is there anything that you do to inform your officers, about taking naps after work before driving home, or making available some sleeping facility?
So as far as what we have done or can do, I'm open to suggestions for sure. As now in my new role as the wellness officer, I'd love to have some actionable things to tell people or to provide them with, especially after a long shift. But what we have done is we do have, our supervisors have, within our policies, the right to kind of, that subjectively, it's not objective. Obviously the policy just gives them the subjective ability to see an officer and be like, hey, if they're run down or they look like they're exhausted, they have the ability to give them rest. Like, hey, return to the precinct, and leave your district. Someone else will cover that district for you. Return here, and give them a little bit of a break. If they're out on a call with them, they have that ability to do that. As far as for driving home, I can speak for mainly myself and say that that is difficult some mornings, especially after a long night, and maybe the end of the morning I was sitting in front of a computer finishing up a report and trying to get home at the end of the night. There have been a few times when I've been thankful for the rumble strips on the side of the road. And so I know that's a problem. I know that we have great policies or practice in place to prevent it. I will say, and I think it'll probably come up in another question here, but this year through our wellness program, we did what Dr. Czeisler was referencing. We took an hour, which is all we could get. Dr. Bowles and McHill from OHSU helped us provide a sleep education class, and it was very well received. People took it to heart and asked a lot of questions. They found it to be kind of what I was just saying, like there's a lot of information in there that was actionable for them, and made them really kind of take an inward look at themselves and how they were practicing their own sleep patterns. And hopefully that will help. It's just the education of letting them know how important sleep is and how not having enough sleep can affect their ability to perform, as well as just even simple tasks. Well, it's not simple, but a task like driving home.
Yeah. That's very interesting. And Michael, I'm going to ask you the same sort of question, because I don't, and also perhaps your perspective on whose problem is it? Is it the employee's problem or the employer's problem that people have to go home tired and possibly put themselves in danger? And Chuck, I'm going to ask you to comment on this same question in a moment too.
Well, I think I'll lead with who's responsible for it or whose problem it is, and we try to lead very I think it's the role of the organization to put into place the right resources to empower people to make choices that are healthy for themselves. I don't think you can get away from that personal responsibility. At the end of the day, we're talking about sleep, and that's something most often done at home. And so it's certainly incumbent upon the person to utilize the resources available to them. But we in the healthcare industry, and certainly at OHSU and beyond, we need to do more, I think. Our workflow is really centered around the patient, as it should be, but it leaves room for opportunity to improve the thoughtfulness in how we create a work structure that brings into account some of these principles that have been discussed here today and others around worker safety and effectiveness. So I think it's a healthy mix of both, and we as an employer want to bring resources through the EAP, and we have a Sparks Wellness program, and I think they're, and this is anecdotal, but I think they're a little underutilized, especially in our ICU cluster. I think one of the things that strikes me as I listen to this conversation is we have a healthcare workforce that's very focused on the patient and at an individual level, and our nurses are wonderful, but they don't take care of themselves in many instances. It's true for leadership as well. So I think we have a lot of room for improvement around not only building the systems, but finding a way to compassionately hold people accountable, hold the system accountable to implementing these things.
Yeah. So I'm going to ask the three panelists. Chuck, I'm going to come to you in a second to ask with the same question, but I just want to get you aware that I think some of the best panel discussions come from the panelists themselves, and rather than necessarily coming through me asking questions. So think about questions that you might want to ask of each other that, some advice from the theoretical standpoint, or Dr. Czeisler, if you have any questions from a practical standpoint that you've always wanted to ask people, please feel free to do so to the other panelists. But going back to this question about, yes, everybody wants to have a vigilant, safe worker and across the night, and there are some compromises that are being made, but one of the biggest compromises might be that safety and getting that person home. Do you have any comments or experience with that, Dr. Czeisler?
Well, thanks very much, Professor Shea. I do think that, of course, it worries me when I hear Officer Parker talk about relying on the rumble strip. I mean, not relying on it, but having and it's not uncommon. We call them wake-up strips. Thank God that that Dr. Ellen Pack worked so hard to get them mandated on federally funded highways after a tragic incident. So I think that, and I'm delighted to hear that there was an educational program that Officer Parker just recently had all the officers participate in. And I think it's important to really emphasize that when you're behind the wheel of a vehicle, that is where, there can be long-term adverse health consequences of sleep deficiency and misalignment of circadian phase. But the consequences when you're behind a vehicle can be immediate, instantaneous, and change the officers' lives and the people around them in the community irreversibly for years to come. And so it is, I think it is something that has to be taken very, very seriously. And the officers should be empowered to have the authority to say, okay, I can't, I'm hitting a wall here. It's not safe for me to be driving. And to find, to get to an appropriate place where they can stop and then develop some sort of policy of what's going to happen from there. Because it's just not worth putting their lives at risk and the lives of others to try to make it that extra half hour, 10 minutes to get to where they're going, because that can be where the tragedy happens. So let me ask Officer Parker, would that sort of thing, would development of a specific policy around that be feasible in your organization?
Thank you, Doctor. I would welcome the development of a policy like that, and I would think that I do think it would be helpful. One problem I would see immediately similar to what Michael was saying about their culture, kind of that shift, is even though we have this policy in place where our supervisors are allowed to kind of like reach out to one of the people they oversee and be like, hey, head back to the precinct. I think you need a little bit of rest. I want to make sure you're doing okay. It doesn't get used often enough, in my opinion, or it's not accepted well by the officer. The officer doesn't want to be seen or feel like we have this culture of trying to make sure that I take all my calls. We have a desire to want to be out there and serving alongside of the other officers working with us. And so we don't want to be the one that has to take a knee of sorts, if that term rings true with everybody. And so maybe a policy like you're talking about would take the subjectiveness out of it and make it more like, okay, you've been going for so many hours, you now have to. And it would maybe shift the culture a little bit to where it's no longer viewed as, oh, I'm going to take my break at the, I don't know what the right word is here, at the expense of all my coworkers and partners. It would be, no, everyone's going to get their break, at a certain time throughout the show. So I think
you're sort of empowering the person and saying, it's okay. This is not a judgment on you. This is a judgment. This is something that we're all going to face. It's been very effective in the airline industry. Dr. Mark Rosekind, who was the administrator, he was a member of the National Transportation Safety Administration and administrator of the National Highway Transportation System. He, when he was working at NASA, showed that a brief nap during the course of transoceanic flights, which they weren't doing. People were falling asleep. 11% of them were falling asleep on these flights while the passengers were in the back, and they would be asleep for like 45 minutes. But people, it was sort of not talked about. And Dr. Rosekind instituted a planned cockpit napping which was a violation. I mean, at that time it was actionable. You would be fired if you fell asleep, even though it was happening all the time. But you could lose your license, et cetera. Well, he instituted this program through NASA and showed a dramatic improvement in performance from top of descent to landing, which is the critical phase of flight. And so I think one of the things that we need to do is to sort of empower people to do that, and to have conversations with people to let them know that this is normal. It does not mean that they're abnormal. It actually means they're normal. And one of the things that it becomes easier and easier as we get older, when the systems in the brain that drive these biological imperatives, when they begin to deteriorate as we get older. So when we study people who are in their 70s and so on, they are more resilient. Because these systems are broken, so they can go. And it's one of the unfortunate things that sometimes the people in charge who are older are like, what's the problem with this? Because they don't have the young, robust systems that are making it. So that's one thing that I would say, whether it's possible to develop those policies, begin those conversations, make it acceptable. And I would also ask Nurse Whitaker whether one of the most amazing conversations I had when I was giving a talk, and I didn't even really dwell on the driving part of it. I was up in Halifax, Nova Scotia, at Dalhousie University, and a nurse raised her hand and said, "Oh yeah, this happens to me. The critical zone of vulnerability when I'm finishing my 12-hour night shift work in the emergency room. And I'm often taking care of people who've had sleep-related crashes and whatnot. And then when I'm driving home, I would often fall asleep while driving. So her solution was to take her ponytail, put it through the sunroof, close the sunroof, so keep going." And I was I didn't even know what to say when she said that, because, by that point, you're so impaired that's not a good strategy. But do you have nurses who are talking about this and sharing with you and others what their experiences are, so that you could also begin to implement policies?
So the dedication of that nurse in that story, I mean, it speaks to a lot of what I see at the bedside of the nurses at OHSU. It's not the right thing. Of course, we all know that, but their willingness to essentially put the job and the patient forward is a challenge in this conversation. It's such a dichotomy as we kind of unpack this a little bit. And the nurses I talk to, they don't bring up driving home much, but I remember getting off night shift and coming off the hill at OHSU and being blinded by the natural light, because I had just spent 12 and a half hours essentially underground in one of the units. And so, I mean, I certainly, that will never, it's ingrained in me deeply, just the physiological changes that happened around that time and the difficulty with driving home. So I'm glad we're talking about it. I would say most of the conversations I have with people are really centered around their patient care during their 12-hour shifts overnight. And so it's really, we've tried to create a culture where we have unit-based nursing practice councils. It's a form of shared governance, and we come together, managers, leaders, and staff nurses, and we try to create essentially internal unit policies that work to meet the needs of the staff and the patients. And a lot of our units in the ICU cluster have centered around this idea of basically collecting or bringing together your breaks to take a meaningful nap, and they're doing that in private spaces. And I'm actually thrilled to hear the pilot story, because I was never really quite sure what the data suggested around if that was safe or effective, or but they report that it helps, and so we tried to make that a reality for them and structure the work that they're doing to allow for that. So I think most of the conversations I have with people are really centered around being overworked, being tired, being being in those patient care spaces where they are worried about their safety and therefore their patient's safety.
That's great, and I think it's great that you're having these conversations. Just to sort of tie a bow around the whole NAP issue, Dr. Rosekinder was very careful in designing that study to make sure that the naps that were scheduled were not so long that they would get into really deep sleep, which has its own challenges, because then the phenomenon of sleep inertia, where you're more impaired when you wake up than when you went to bed, can be a real problem. And
could you estimate a time amount for that?
Yeah, so it's sort of a 20 to 30 minute nap, but then there's even been another wrinkle. Research out of Washington State University, the scientists there have shown that if you can minimize sleep inertia, this is the work of Hans van Dagen there, you can minimize sleep inertia by taking caffeine before you start the nap, because it's going to take half an hour before it gets into the system, so it's sort of a caffeine nap in which you are it's not going to prevent you from going to sleep if you take it right at the beginning, but then it kicks in so that you're not so deeply asleep that you can't wake up at the end of the nap. So that's something that, and again, I can send Dr. Van Dagen's paper about that if you would like, Steve.
Thank you. We've had a number of questions in the chat. A lot of them are about the complexity of all this and the sort of idiosyncrasy regarding different professions, and Sue Downs talks about nursing and the differences between 3 12-hour shifts and 5 8-hour shifts per week, and another is it rotating or not? Is it permanent? These are issues that we're probably not going to be able to sort through because they, in great detail today. And you feel free to comment on those, but I'm very, there was another, in the trucking industry, of course, they have some regulations on work hours, which do help, presumably, in this regard. So I'm going to come on, in a moment, I'm going to ask about what shift work does to the family. But before we do, regarding the complexity of all this in terms of permanent and rotating shift work and 3/12s and 5/8s and truck drivers, has it really worked is that the best thing to do? Have regulations around it? Do any comments on the specificities of whether one type of shift is best for a specific operation?
May I comment on that?
Sure, go ahead.
I think that it really, unfortunately, it is complex because the operational needs are different in different settings. So when I talked before, and I sort of think of this as kind of a Venn diagram with 3 interacting circles. One is the needs and preferences of the employees, which are obviously critical. The other is the operational requirements of the job. And then the third is sort of the biology, which is often not at the table in these discussions. And so I think it's important to sort of try to come up with solutions that are where these 3 different circles overlap. For example, the Columbia River bar pilots out in Astoria, Washington, have some of the most challenging schedules that I've ever seen, because they have to be available for the next ship that's coming in. They don't know when it's actually going to be arriving. They have to do a transit across the most treacherous bar in the world. Often in the middle of the night, I've climbed the Jacob's Ladder to see what it was like at night to go up to one of these container ships. It's a little bit terrifying. climbing up the side of the 4 stories onto the vessel, and then you're on the deck of this huge ship, and all the lights have to be out. Even these sea captains, because the trip is so tumultuous, are on agents to prevent them from getting seasick, which are the same agents that you take. That's the most common selling hypnotics over the counter. It happens to be the same diphenhydramine that is in those agents. So they're taking essentially sleeping pills. It's the middle of the night. They have to be dark to see it has to be completely dark so that they can get their eyes, so that it takes about 45 minutes of adaptation so that they can see the little buoy lights. You can't have the same scheduling solution for that group that you have for nurses working in the ICU, or that you have for police officers, or that you have for firefighters who can sleep in the firehouse, so their shifts often are longer. So as much as it would be great to have, one size fits all, this is where that cliche, it just doesn't work. And so there have to be occupation-specific solutions, I think.
Thank you, Chuck. Any other comments maybe then on Sudan's question about the 3 12 hours versus the 5 8 hours? Which is more popular? Which is more unpopular with the employer, and which is more unpopular with the employee, and which is more popular? Which is better for the physiology? Just to fill in that triad that Dr. Czeisler mentioned.
Well, I can only offer what the employees tell me, and the employees are very much, they appreciate the 12-hour shift and the 4 days off per week. And many of them are working extra these days, which is very commendable, but takes a deeper impact on their well-being. But yes, I think to move the majority of nursing away from that 12-hour shift would take a complete sea change in the way that, in what draws them to the work, honestly. It was one of the things that drew me to nursing early on, and it's that important, it's that ingrained, and I think it would be a very hard thing to change.
Yeah.
As far as the hospital, what the hospital prefers, I can't say that I have heard one conversation or the other. I think this is the way, unfortunately, this is the way it is and has been for quite some time. I haven't heard of any desire to move away from it, other than to do what's right for our staff and our patients. So I think really what it comes down to is putting this at a higher level of importance from which we actually break some of that inertia and make meaningful systematic change. And again, it comes down to a very long list of stakeholders and people who put others in front of themselves. And so I actually want to call out Dana. I apologize if I am mispronouncing your name, but she kind of highlights some of the challenges in the healthcare setting, and ultimately asks the question, like, kind of going back to, is this only the employee's responsibility? And I just have to say emphatically, no. A member of our nursing leadership team sometimes highlights the construction work site and the change. I don't know when that occurred, but the change to enforce hard hats. And now you can't even step onto the work site without a hard hat. And at some point that was a change, and it probably didn't go over too well. And it was essentially a top-down mandated change. And I do think that we're at this point of inertia where some of that top-down leadership has to occur. And I just think we're having a hard time in healthcare in general. It's very hard to break any inertia, let alone refocusing on such a large change. But it's very likely the right thing to do.
Right, and I feel that there's a lot of evidence out there that we know what the right thing to do is, but pushing industries and regulations in that direction is tough, and I think it's been a lifelong work of Dr. Czeisler, and he's had many battles, won some, lost some, but has been pushing all the time based on theory plus studies that you can point to that work, trials of different interventions. And that would seem to be compelling to me, but then you need to have the right outreach and education of probably everybody in order to get any change. So Neil, do you have any comments about the rotating shifts or permanent night shifts for your workers, which is better from the workers' perspective?
As far as which I think they would find better, I think that would be kind of split for us. So our agency is run on a seniority-based system, and so, like, for instance, the beginning of my career was on night shift, but then I chose to stay on night shift for a very long time because I liked the shift. I had grown comfortable with it. Contrary to all, to everything I've learned, I felt like I performed well on night shift, and then I got to day shift and realized that wasn't true. But I guess I would almost mirror the question back, because I listening to Dr. Czeisler's keynote speech, I actually kind of wrote down some of these things. Is like, for us, it would have to be a creative solution, because I think, based on a lot of the stuff he was showing and some of the stuff that we learned from Dr. Bowles and McHill's material they gave us to provide it in service, it's our night shifters we got to protect in some way. We got to do something to maybe, I don't know if it's we shorten their shifts. So maybe our day shifters work a 12-hour shift and our afternoon shifters are maybe on a 10, and then our night shifters are on an 8 and they do 5. I don't know if that would even make sense logistically or how we manage that. But that way they're not out there doing that 10 to 12 hours, kind of going through, I forget what he was calling it, but that, sleep maintenance area, and not even able to get quality sleep because they're kind of working past those hours. And even on the hours they do get to sleep, they're not able to get quality sleep. So oh, go ahead.
One of the things, that's a great point that you raised, and it reminds me of one of the things that we learned when we were working with the Philadelphia police in the 1980s. And some of on that website that I showed you, the understandingsleep.org, some of the testimonials from that group are available there if you want to take a look at it. I believe it's in the second module. But the point that I want to make is we learned, gathering statistics from the department, that the crimes also had a daily rhythm. And so when we looked at the calls for service, they peaked in the evening in the wake maintenance zone, and they had a nadir of calls for service at 5 o'clock in the morning. So the criminals are affected by the same biology. And so we introduced there the concept of proportional staffing. So we actually had a bar shift in the evening when the calls for service were greatest, that went from like maybe 6 in the evening till 2 in the morning or something like that. And we had more officers scheduled when there were more calls for service, and fewer officers when there were fewer calls for service, which are the most difficult times to staff in terms of biologically hitting the wall, so that they could actually go home at 2 or 3 in the morning instead of staying all, because we had this quote unquote bar shift that was in the evening, ending at either 2 or 3 in the morning. Maybe it was 7 to 3. I don't remember the exact time. But so they were there, and they ended right before that critical zone of vulnerability, so that they could get sleep. So I think that, and then they had fewer people there than when they had fewer calls for service, and when it was biologically the most difficult for them to be there. So I think that you can use creativity once you begin. That's one of the reasons why I think education is so important of the workforce and of the staff, of the people running, of the administration, as well as the staff, because then you can begin to come up with solutions that you don't need the same number of people there at all hours of the day and night, because the demands may be different at all hours of the day and night. So we might be able to start thinking differently about how we staff.
I think that'd be I think that'd be great. I was just going to add just real quickly, you know, we've, fortunately I lost my train of thought right as you ended there, but we've tried some variations of proportional staffing, but your point to education, I think is very well taken, and we're hoping to do that. I've mentioned this class we put on, it was only an hour. It's all we could get, you know, freed up in our training schedule this last year, but we're hoping to continue it. And part of that training is all of our chiefs, our commanders, our captains, and our lieutenants went through that training. And so they got to see the data that OHSU doctors kind of presented to us. And it included a lot of data on driving and how your physical skills, your physiology affects these skills so much that, you know, you start to make more errors. And so they got to see that. And so our hope is to continue that. But the last point I'd make on that is I would refer back to, I believe it's Dana's comment here. We have so many stakeholders that it's going to take, it's like, you know, turning that a big ship. It's going to take us some time, I think, to get everyone educated and then maybe get one unified kind of movement towards something that is beneficial as far as it relates to our wellness and sleep in our agency, especially because, you know, each of those individuals have their own competing interests, right? I think I see in your, you know, collective bargaining and you know, we have all these same issues that Dana was pointing out for OHSU here at the Police Bureau. So, but education, I think, is huge, and we're hoping to continue that so that maybe we can get to something like you're talking about with proportional staffing, or, you know, some altered schedule to benefit our employees, not just because it benefits our community, that we have officers that are well rested and can make good, sound decisions, reasonable decisions, but also benefits them and their longevity and their families. And you know, it's got such a radius that it'll start affecting if our employees are healthy.
Yeah, I mean, you know, we I'll tell an anecdote about our work with Philadelphia. So we introduced a schedule. We trialed it in one district. It was wildly, we had them, they were working also 4 consecutive shifts, and then we had them stay on the same shift for 3 consecutive tours. So they were working 4 and 2, and then they would rotate it, and they'd do 3 of those, and then they rotated to the next shift, to the evening shift, and then to the bar shift, and then to the night shift and the day shift. Anyway, so it was very popular. 95% of the officers wanted to go on it. The union wanted to do it. Then there was a dust up with management. New commissioner came in. That's a long story, but anything the old commissioner initiated, which included our program, was thrown out, and they were put back on their old schedule. And then the amazing thing was, because they had been on this for a period of time, they were like, oh my God, the crash rate has now gone up 25%. So they put all the drivers into driver training instead of putting them back on the schedule that had reduced their crashes. And then I had to test it. I was like 11-hour, you know, arbitration hearing and whatnot. Eventually they were put back on but it was a 3-year grueling process. As you say, Professor Shea, some wins, some losses, but yeah, this was one that we fought for quite a while. And I used the fact that they had put them into driver training because they didn't understand why when they put them back on their old schedule, the crash rate went up. Because these are all interrelated issues, and they don't, sometimes the administration doesn't really see what the consequences of their actions are.
Well, you know, I think this has been a great discussion because it's highlighted that it's complicated. It's highlighted that there are some individuals that may react differently and may have better different tailored solutions for them. And also with Dana, they highlighted the responsibility of the administrators and the policy regulators for each industry to come up, put it on their shoulders instead of the individuals. But then again, the individuals will have different responses and different preferences. And some of that, I'm going to move on to this question I mentioned before about the impact of shift work on home life. And are there any stories that would that you would highlight of the importance of that, and maybe if there's anything you've learned from your experience in ways that can, again, I don't want to put it all on the individual, but are there techniques that improve home life in your experience for the night shift worker? Michael.
I have lots of conversations around this with staff, and I lived it for a relatively short period of time. Our staff many of the people I talk to have partners that work regular shifts, and so they often end up being ships passing in the night, and it definitely creates a relationship strain from that perspective, not having enough quality time with your partner. Life has gotten only more difficult since COVID and the logistics of childcare and all of those things, and a 12-hour work shift makes it difficult. I know from dropping off kids at daycare, and not enough daycares are open at the extended hours that healthcare workers need, and so you're constantly just juggling this very difficult, very complex set of tasks that you have to accomplish, and then you add on top of that being tired, deeply tired. And I know from personal experience hanging out with friends and spending time, sitting on their couch, and then randomly I would just fall asleep in the middle of a social gathering. And I hear that from our staff too, that it's not just me. And so, yeah, I mean, all of these things, I think ultimately in the end, they don't strain relationships as in you might lose relationships, but you lose meaningful time. And I think that that's really key in a lot of the work that both officers and nurses do. It's difficult work, and you need something that recharges your batteries and fills you with energy to go do that hard work. And so I think that's true of both shifts, but I would say it's harder for our night shift folks to have that meaningful time. And then there's always the question of, well, I've just worked 3 12-hour shifts on night shift. Do I try to transition back to a day shift? And essentially you waste that day, and that day's very complex to begin with. So you're really working more than that 3-day a week. You're trying to account for shifting back and forth, and having a social life, and having hobbies, and all of the things that you need to take care of yourself. So it's very, very difficult. I don't have a solid answer for that. It definitely strains relationships, and my hope is that, and again, not all on the individual, but certainly I hope that people are having those difficult conversations with loved ones and strategizing around that. Support structure is definitely key.
Thank you. Neil, do you have any comments for the police in the same vein?
Yeah, I think I'd essentially be echoing everything Michael said. Is we have all of the same issues. I can speak for myself, being on night shift for 10 years. Thankfully, at the time I didn't have the complexity in my family of children yet, and so it was just me and my wife trying to navigate that, the shifts and having opposing shifts. And like I think I can't remember if it was Michael or Dr. Shea that said the ship's passing the night, but that's essentially what it was. Is I would arrive home as she would be leaving, and then on top of that you have the social events of all the things that tend to happen on the normal day shift schedule. So the dinners and the evenings, and and when we're talking about shift work, I think another thing that we're not necessarily talking about today, just basically we're talking about sleep, but the other part of that is, it's 24/7 operations. So you're missing holidays and, weekends, we don't work the Monday through Friday. And so our officers are often doing everything they can to find creative ways or solutions to at least make some. So we've had to kind of look at it in a way, like when we gave that sleep training, it was all, one of the things we said with it was, hey, we're not trying to say that you have to get 7 to 8 hours of sleep a night, which we'd love for you to get, but based on their schedules and the family situations at home, and the short staffing that I think that Michael was referencing for the nurses we have as well, the overtime that they're working, we just want you to focus on it when you can get it. Try to start, prioritizing sleep, because we didn't want to really shake it up and tell them like, well, everyone needs to get 8 hours sleep. There's no, questions about it. We wanted to give them something actionable that they could do. And so our request after the training was, kind of how we let them go out the doors with all this information, how can you personally in your own schedule, based on your own circumstances, take this information and improve your sleep, which we had kind of related to improving their life and improving their schedules and improving their time with their kids and their families and their friends at home. So that was kind of our hope at the end of the training they would take from it. But anything I would say specifically would be anecdotal, and also I think mirroring exactly what Michael was just saying, is we have great issues with scheduling and this, and we do have officers. I will say that our newer generation of officers does seem to prioritize a work-life balance more than our older generation of officers, and I think that's a good thing. And so we kind of want to foster that. But also then you have the operational standpoint where we have people who are saying, well, hold on, we need more overtime out of people too. And so there's always competing interests, obviously.
Right. Well, Neil, Michael, and Chuck, thank you so much. It's been a really, really interesting discussion. I know that probably we've raised more issues than we've solved, but the rest of the day, one of the solutions is education, and that's what this day is all about. So discussing these problems, it's been fascinating. I'm sorry if I didn't get to all of the questions. I tried to push a few together, but I think we're learning a lot. And everybody probably needs a 5-minute break before the next speaker. So please go ahead and take that. And if there's one thing that I would suggest you do when you get the slide deck is look at slide 76 of Professor Czeisler's slide deck, which is the components of a comprehensive fatigue risk management program in safety sensitive occupations, which says it's a great summary of where his work has led to. So I suggest you look at that. John Emens actually worked for in Dr. Czeisler's group many years ago before he went to medical school, and Dr. Emens went to medical school in University of Massachusetts and completed his internship in psychiatry and psychiatry residency at OHSU. I have also, since I came to OHSU over 10 years ago, Dr. Emens was the first physician that I approached to come and help us with our circadian work. And he's been a really valued colleague as a researcher and providing a sort of clinical screening of our participants in addition to that over that entire period. I've really, really enjoyed working with him. He has a lot of research on circadian rhythm sleep disorders, in particular non-24-hour sleep-wake rhythm disorder. He studied lots of circadian rhythms in blind individuals and looked at sleep and the effects of sleep apnea and obesity and circadian misalignment on mood disorders. He's board certified in psychiatry and works at both the Portland VA sleep medicine program as well as psychiatry at the Portland VA, and has a position at OHSU as well. So it's a great delight to see John talk about shift work and mental health. John, are you with us?
I'm going to get started then. Apologies for all of the technical difficulties, but we've kind of jury-rigged this. So I'm going to be talking about shift work and mental health, and I've kind of switched things up a little bit and kind of talk about some of the actual shift work data first, and then kind of go backwards and talk about some background around how circadian rhythmicity and mood might explain some of the findings around shift work and mental health. So I'm going to go through this a little bit in the interest of time, a little bit more quickly. This is actually a rare prospective study. A lot of these studies are observational studies, but this is one in which they actually look prospectively at the impact of shift work. And
John, can I interrupt you? We can see you're not in presenter mode yet. We can see all of the slides.
Oh, I am showing myself in presenter mode, so that is odd.
Okay, well, we just carry on. We can just see it. Now you're on slide 3. Go ahead.
Okay, I will continue. And what they basically found was that at least in an age-based and gender-based way, that incident depression was higher in those who were doing shift work, at least in one of the initial models that fell out when they adjusted for a lot of other potential confounders. And so that was interesting. And similarly, in their kind of more observational piece of this study, again, they found that your odds of either depressed mood or frankly meeting criteria for depressive disorder were higher for those who had been current or former shift workers compared to the non-shift workers. And a lot of these observational studies were nicely summarized just a few years ago in this meta-analysis. And this meta-analysis included a negative study, a large nurses study that didn't find an association between shift work and depression. But overall, they found a significant odds ratio of 1.43 for doing shift work and depression. And many of these studies are looking at depression specifically. Some will look at anxiety, but that's the most common. So
John, sorry to interrupt, but you're on slide 3 on my screen. I don't know if it's the same for others. Now it's just advanced now.
All right. Hopefully you can now see my slide,
Yeah.
not in present.
Yep, slide 7.
Okay, I'm going to advance to slide number 8. And so again, the key here was, again, the higher odds ratio of depression. Interestingly enough, this was a gender-dependent association on slide number 9. Hopefully you all are seeing that.
Yeah.
And where it was really significant in women, but not in men. And as Dr. Czeisler was talking about, their circadian differences between men and women, as well as differences in sleep. And we'll touch upon some of that maybe a little bit later. That might have some bearing on that different finding. Belabor all of these studies, but the next one is, I think, an important one. A UK Biobank study had a large cohort of folks studied over many years. This is, again, slide 10. Shift work in a significant fraction of those. And they did some good defining of shift work and night shift work, as you can kind of see there. And they also did some decent assessments of mood, looking at neuroticism, assessments of kind of both depressed mood, frankly, and anhedonia, and then asking if folks had seen a primary care provider or had complaints of mood instability. And this is basically what they found on slide 13, where you do see these associations with shift work when comparing shift workers to non-shift workers, both in anhedonia, frank feelings of depression, it's neuroticism assessment questionnaire, which is really kind of gauging someone's level of anxiety and stress, as well as resilience to stress and mood instability. And what's interesting is that when they split people up into day shift workers and night shift workers, it was actually the day shift workers who most consistently had kind of higher odds of these mood outcomes compared to even the night shift workers. And then I think the last shift work study, again, in the interest of time, that I'm going to go through is a shift work study looking at, this was actually a randomized controlled trial that they got this data from, where they were looking at people with shift work disorder. So these are individuals with symptoms of insomnia and or hypersomnolence in the setting of doing shift work. So they completed a standardized questionnaire to kind of find folks who had a high risk of having a shift work disorder. And these were folks who were doing both rotating and kind of permanent night shifts. And then they did some really great assessments of mood, looking at a very standardized questionnaire for depression, the PHQ-9, as well as for anxiety. And what they found was that those people, those individuals who had a high risk for sleep, for shift work disorder in the open white bars had a greater association with both depression as well as for anxiety. So again, those at high risk for shift work disorder, again, having greater anxiety and depression symptoms. I always like to throw this in because I think this is very important. You know, when we think about shift work and mood, and this was a study that came out a number of years ago, where they looked at health registry data for completed suicide using the NVDRS, the National Violent Death Reporting System, covering a good portion of the United States. And when you control for the probability of people being awake, your risk of suicide is greatest during the nighttime hours. Most suicides occur during the day because that's when most people are awake, but your risk based on the probability that people are awake is actually greatest at night. So I think the data in total suggests that there's something vulnerable. There's a vulnerability in terms of our mood, including to the point of suicide, about wakefulness during the night, about the restrictions in sleep that happen with shift work, or the misalignment between the timing of the 24-hour body clock and the timing of wakefulness that really put us at higher risk of both depression and anxiety. And so just, I know we're kind of short on time, but just by way of explanation, I just want to talk about circadian rhythms and mood really quickly, because I think that really has the potential to explain a lot of the vulnerability in shift workers to mood disorders. So just a quick refresher, we often will measure what time it is in someone's body by marking an output of the clock, in this case, timing of melatonin. And here we're using the dim light melatonin onset, which is the onset of melatonin secretion designated by that red dot, and has a typical relationship to the timing of sleep, which is also the timing of our dark period. And what you can do is you can schedule sleep at all different times and assess mood across the circadian day and night at all different biological times, not just different clock hours, while controlling for the amount of prior sleep. When you do that, you actually find that negative mood states, designated by the frowning faces, peak during the biological night, and positive mood states plummet during the biological night. And I'll show you the raw data for that, but I think a schematic is a little bit helpful to kind of understand the raw data. So during the biological night, our positive affect, or positive mood states, which we might rate with kind of how much we are feeling a particular work. How much do I feel happy or excited or joyful versus kind of sad or tired? And when you do that, this is what you find. So to orient you to this figure, these are measures of both positive mood and negative mood that we assessed at all different biological times. The 0 on the bottom y-axis represents that onset of melatonin secretion, which you can think of as the beginning of the biological night. The large gray rectangles, habitual sleep timing outside of the laboratory. And the solid black line and smaller dashed line represent assessments of negative mood states. And you can see those really increase during the habitual sleep period, peaking kind of just past maybe the middle of the biological night. At the same time, positive mood states and positive mood really drops during the biological night. And so you have these two reasons why we might have worse mood during the biological night, and conversely during the biological daytime, we see increases in positive mood and decreases in negative mood. And so this could play out if I'm doing shift work. So if I'm awake during the night, I'm exposing myself to these worse mood states that I'm typically are shielded by sleep. But that also might occur if I'm doing kind of morning shift. Because similarly, I might be exposing myself to some of these negative mood states, if I'm having to round at 4:35 a.m. in time for my 7 a.m. surgery. And in addition, it's possible that kind of the alignment between the timing of my clock as measured by this profile of melatonin secretion and that red melatonin onset, and the timing of sleep and other activities could also impact my mood, as you might expect to occur in shift work. So just by moving my clock later relative to sleep, as I'm doing here as I move through the slides, has the potential to, again, move some of that minima in mood into the waking hours. And that could be associated with worse mood as well. And that we've also found. So as that red double-headed arrow gets smaller, that interval between the timing of the clock and the midpoint of the sleep gets shorter in hours, we might expect a worse mood. And that's what we found, both in individuals with depression. So this is on the x-axis, that interval between that melatonin onset in the middle of sleep. And as that gets shorter, the timing of the clock moves later relative to sleep, we see worse depression ratings. And it's not just in depressed populations. So this is something that's in submission right now, where we looked at healthy individuals and assessed mood using the profile of mood states. And again, that interval between that melatonin onset and mid-sleep, as it gets shorter, you move from left to right on the x-axis, we have worse moods, even within the normative range. And in a mixed model analysis, this was significant, even when we're including kind of gender and other covariates, because we repeatedly assessed this over time. This might be a possible explanation for why we are at higher risk for depression and anxiety when we're doing shift work. And in the interest of time, I might just skip through these last slides, but I think this is similar to what we see with social jet lag, this difference between sleep-wake timing on free days versus kind of on work days. In red and our free days in green in this example, that difference in mid-sleep, in this case of 3 hours, is pretty common. That's a pretty subtle misalignment or change in your alignment between the timing of sleep and darkness and wakefulness and the timing of the clock. And also has been associated with worse mood states. So the greater those shifts on the weekend, the greater that typically shift to a later time, the worse your mood is measured on the Bechdel scale. So I think there's a lot of basic data in terms of circadian rhythmicity in mood and circadian alignment in mood, as well as some of these other examples of maybe more subtle changes in circadian alignment that occur compared to shift work, that all, I think, alter the idea that that misalignment between the timing of when we're awake and the timing of our clock could contribute to the development of mood disorders. With that very quick race through my slides, I'm going to try and still end only a little bit late. So again, apologies for the difficulties, and thanks very much.
Thank you, John. That was great. Considering the technical difficulties, you did an amazing job of getting through that material. We just have time for maybe one or possibly two questions. Leslie Hammer has her hand up. Leslie?
It's actually a clap. But Steve, you actually read it. It was a hand up, but it was meant to be a clap. But John, thank you so much. And I'll just point out, I did make a comment in the chat earlier that these findings, it's also interesting because the recent findings on youth depression are coming out and so clearly linked to their utilization of social media during the nighttime. And so there's there's so much that needs to be done here in terms of getting this information out, and the impact of sleep on mental health is tremendous. So thank you again.
Thanks. And I just, again, I think kind of in ending, I think the thing I think to highlight is that it typically shifting of our timing of our 24-hour biological clock to a later hour, there's a tremendous amount of data, everything from greater prevalence of depression in kind of night owls to kind of some of the data I presented that shows that it's those shifts to a later hour that in the timing of our clock that are really detrimental, and that's again what you're going to see in teenagers who are being exposed to light at night, as well as in a lot of shift workers, people doing evening shifts, potentially being exposed to light that's going to shift them to a later time.
Thank you, John. There's a comment from Judith. It sounds like everyone might be working with everyone else who is working at their night negative mood. So that I guess the collective mood may be very low. But Momoko Cordova asked the question, what are the effective educational resources that can be implemented to reduce mood or maybe improve mood that may affect supervisor-worker relationship? Last question.
Yeah, well, toughest question for last. I mean, that would be the next piece would be, Dr. Czeisler was talking about kind of interventional work. And I think the thing that would be most helpful would be anything that would help with adaptation and shifting of the clock so that I have a relatively normal alignment between the timing of my clock and when I'm awake, so that we can shift those negative mood states back into the sleeping period so I'm not being exposed to them anymore. So ideally, that would any of those interventions that are geared towards adaptation to shift work are going to be the real solutions. And there's no data that I'm aware of that some of our other adaptations, whether it's caffeine or napping, can really get around this physiology of being awake during very negative mood states in the night.
Okay. Well, John, we're going to end on time. That was brilliant. Thank you so much. And I apologize for the technical difficulties. And so they can't hear you because I'm speaking into my phone, but he said, as do I. Anyway, we're going to stop for lunch break now. It's lunch on the West Coast, noon on the West Coast. We'll reconvene in half an hour. So see you then. Bye.
All right, I'm going to kick off the afternoon session. My name is Saurabh Tosar. I'm a faculty member and assistant professor at the Oregon Institute of Occupational Health Sciences. I study how common behaviors like sedentary behaviors and sleep and the internal body clock affect heart disease risk in humans. First off, I want to thank Dr. Shea for facilitating an outstanding morning session, and for everybody who participated and the questions, and it was really wonderful. Before we begin the afternoon session, a reminder to please contact Amy Spring if you want SHRM credit. Also, please complete the evaluation form at the end of this symposium. We take feedback very seriously, and we incorporate that into our next symposiums. So to start off, it is my distinct pleasure to welcome our next speaker, Dr. Nicole Bowles, and session participants Travis Chipman and Cameron Homan. Dr. Bowles will lead a panel discussion along with representative stakeholders on her recent work with Portland Firefighters Association and Portland Police Bureau's Wellness Program. Dr. Bowles graduated with her Ph.D. from Rockefeller University and earned a master's in clinical epidemiology from Weill Cornell Medical College as a health disparities and community engagement research fellow. She joined Dr. Shea's laboratory in 2016 and was funded by a Ford Foundation Fellowship for her work. Her research encompasses a broad spectrum, really, from basic to translational work, and it focuses on the interplay between stress, endogenous circadian rhythms, and the endocannabinoid system in humans. I think she's a leader in this work with emergency firefighters and emergency workers, and I'm sure you'll love hearing about it. Travis Shipman is serving in his third 3-year term as a Secretary-Treasurer of International Association of Firefighters, Local 43 in Portland, Oregon. For 21 years, he has worked for the Portland Fire and Rescue as a firefighter. Travis is very excited for his partnership with OHSU that was spurred by the work of Cameron Homan. At home is a very supportive cast, and he is beyond thankful to his family for the endless support in this challenging work. Cameron Homan has been a firefighter for 9 years, 7 of which have been at the Portland Fire. He has been a member of Local 43 Executive Board for 4 years, and third-generation public servant and second-generation firefighter. And he is also thankful. He's married with 2 children, and is very thankful for his family for support in the challenging career that they have. So I want to welcome Dr. Bowles, Travis, and Cameron. And I will hand over the mic to Dr. Bowles.
Thanks for the organizers for having us to lead the session on the community engaged approach to improve the sleep of first responders. Sleep in the title here, as this is the sleep symposium, but really looking at the overall health of first responders. I don't know, do you guys have any comments first? Or do we have any questions from the audience before I can jump into some of the questions I have?
I would like to start off, Dr. Bowles, just saying I appreciate, when we started this this whole entire project out, it really morphed into something way more than I ever could have hoped for or expected. Working with Cameron, I tasked Cameron to go out and find someone that could help us understand the schedules that we work and how that impacts us. And ultimately, like you had said, which schedule is going to be the healthiest. I just had no idea how amazing your team was going to be. And I continue to appreciate the things that you have done. Almost all of our fire stations and bedrooms now, have blackout blinds. I believe that's part of you. The information that I've gotten from you, I've taken to the labor management meetings and controlled thermostats in our sleeping quarters. I mean, all of those things when we talk about sleep hygiene are directly the efforts that you've put forth in the last few years. So I would like to thank you and your team for continuing to put up with what we're asking you to help us solve. So thank you.
Thank you. No, put up, but I'm always like, I feel like I'm never doing enough. I'm like, I've got to get the data to them. No, I've loved working with you all and I've learned so much.
I'd like to also echo Travis's appreciation. It's been really amazing to have this partnership with OHSU, and especially to have a partnership with an organization in our own backyard here. It has helped us make these data-driven decisions and helping to make our organization be more efficient for our membership and improve our employee satisfaction.
So I think I see any questions in the comment box. And I think you touched upon this a bit, Travis, when you mentioned when you tasked Cameron with the efforts, but maybe you can touch upon it a bit more. What could you tell us? What led you to our institute? And what made you, I guess, more interested in the schedule components?
Well, there was a vocal part of our membership and the firefighters that wanted to understand, and they wanted to move to a 4896. We knew that the 4896 was the healthiest, as busy as we are. So we developed this new schedule, the 1323, which now is called the Portland schedule, and I'm getting calls from far away as Texas and across the country to ask about what data we have and how's the schedule working and the surveys that we've gotten and taken from you. So it's a big deal. But initially, just reaching out to you to answer the ultimate question. And, I just remember, Dr. Stephen Shea, he just kept saying, well, 24 hours is bad, Travis. 24 hours is bad. And we just had to get over the point where that wasn't going to change. So then let's move to the next option. So that's how we came to coming to OHSU.
So to answer your question, Leslie, on shift, the total amount of sleep has not changed, but on the second day on the new shift, there is 20 minutes more, but collectively it doesn't impact the total amount. But there is, sorry, I think 20 minutes is on the off shift. There's about 15 minutes more sleep on that second day.
So it's changing the sleep and I did see that it's changing the sleep on the off shift days, but not on the during shift days.
Yeah, no, it's a little bit of both. So on the off, it's both on the, it's on the second day in both cases. So the second day on shift, there is slightly more sleep, and on the second day off shift, there's slightly more sleep.
Oh, that's great. That's great. So all of those other kind of affective responses are also showing up in your objective data on both during shift and off shift.
The mood, the more mood. So I haven't, the answer is yes to that, but I didn't show that here. So we do have like daily mood and things like that. And so like levels of calmness is improved on the new schedule, both on shift and off shift. I haven't like associated that with sleep or anything yet. That is answering that question.
Thank you.
Okay. So what does sleep health mean to you, and how did you come to recognize the importance of it in your organization?
Well, I think for our organization, we recognize that being that we are on 24-hour shifts that are variable in nature, and we have a very high output when we are called to action in the middle of the night. Those sort of elements were never going to change. So we were trying to find as many sort of ways to mitigate the risks and the health kind of impacts as we could. So to answer your question, we put a high value on getting our employees and our members to sleep as effectively as they can on shift, and it's proving to be quite positive with the results that we've been able to put into place.
Yeah, I mean, that was one of the more striking things when we started our focus group was the dedication to sleep that was already shown in Portland. I mean, I have still come into contact with fire departments that still have bunk beds. There are those that, and I think Travis, similarly, people are reaching out to us asking about the 1323, but they'll note that they're not able to nap, or they're not able to go to bed to a certain amount of time. And that's still the fact that that is a restriction. I'm sure it's related to financial reasons, but the fact that someone's not even able to go to sleep when maybe they need to is concerning. And so it's nice that there are already those type of structures in place in Portland. So someone in the comments notes that their firefighters work 10-hour days and 14-hour nights. I'm curious what city that is.
New York.
Oh, okay. I was saying, yeah, I thought New York did something like that.
They work at 10-14, and honestly, most of them trade into a 24-hour shift that keeps them in a 24-hour rotation without messing up their schedule. They have some specific rules that's specific to that area, and so that is the schedule that they work. I did want to make one comment. The reason that I think 96% of our membership wants to stay with the 1323 instead of going back to the 2448 is because of the maximum days off. In a 4896, when you get those 4 days off, that fourth day really doesn't make an impact for your health and wellness. And earlier this morning, when one of the presentations, the comment was made that the circadian rhythm does take around 72 hours to reset. And that's what we're finding is that by maximizing the number of 3 days off you get and minimizing the number of doubles that you work throughout the year, you're actually maximizing that health band in that 72-hour window, and then getting back to work when you're the healthiest and not wasting that fourth day. And I think that's why we're seeing this schedule really pick up a lot of steam across the country. Tualatin Valley now has negotiated what they call a D shift, but it's the exact same thing as a 1323, as well as Clackamas has negotiated the same thing. So this whole region around us is going to be going to a version of 1323, which to me is very exciting. So I appreciate the work that you've done, but also when we look at those point analysis diagrams that was done early on in the process, I think that does a great job of highlighting the overall health aspect to the schedule.
So initially, when you were going towards the 1323, I think it was also with the idea that you could eventually move to the 13, like a 1313. Is that?
Yes. Yep. Yeah.
So how is perhaps those conversations progressing?
Well, honestly, very well. The last contract, since we initially started this work, we have 3 more Kelly days. And what that means is that's essentially 3 less doubles that we're going to have to work, because every time we get a Kelly day, it actually takes one of the doubles away. And so ultimately, that's our goal. We're at 50.4 hours a week. Once we get down to 42 hours per week, which is a big lift, a lot of new employees, then we'll be on a 1-3 period. So.
And then similarly, I think some of the results are in a way muted because the last cycle there was a lot of mandatory overtime. Have you seen that lifted, or are there talks on ways that can be improved?
Cameron?
I think if it had not been for the mandatory overtime that's kind of struck our department, after we had moved to the 1323, I think had that not occurred, I think our workforce would have collapsed under the pressure, quite frankly. It was very common for our members to be forced to stay at work. And had we not been on this new schedule, given the opportunity to have now 2 days to recover as opposed to just being 1, had we stayed on the old schedule, our membership would have collapsed under the pressure. So ideally, we don't have mandatory overtime. I know our department as well as our union have pushed hard in the last year and a half to hire more people, so that's not the case. It is slowly improving, but it is still a challenge that we are facing. But we are grateful for the fact that it did occur while we were doing the 1323 schedule, because we would have probably had numerous accidents, members driving home tired when they shouldn't be, or workplace injuries that would have occurred just from working so many consecutive shifts.
Yeah. So I've kind of asked this question already, but what would you envision be the next steps of additional measures that need to be taken, additional interventions that could be put into place to additionally reduce the burden in terms of the number of calls and things like that? I guess it's a 2-part question. So the first is, do you see another step, or are there other things you'd think would be useful to measure?
I know for myself, and this is more of a social issue as opposed to a health issue. I guess you could possibly relate the two, but I think it would be very interesting to look at the correlation between relationships and divorce rates at our busy stations as opposed to the slow ones. I know for myself, I can speak sort of anecdotally to the fact that we have some stations that the firefighters are running, 3,000-4,000 calls, as opposed to the members at some stations who are running, 500 calls. And I could specifically think of many examples to where the members who are in these stations that run very, very high amounts of calls are suffering higher rates of divorce than the members who are at the slow stations. And I that's sort of just an anecdotal perspective. But I think that would be very interesting just from a social sort of a standpoint to take a look into that and see the effect that call volume has on relationships.
And then, yeah, the second question was about other interventions. So even I think Dr. Czeisler earlier, and I think it was Dr. but there was talking about having like extra firefighters available for times when there are higher call volumes and things like that.
We in the bargaining process, we're looking at adding more paramedics to one rig, which would reduce the amount of workload that's put on one person, such as a paramedic officer. And then I think as far as the relationship with OHSU and looking into firefighter health and safety, approximately 3 months ago, a 51-year-old firefighter with Gresham collapsed on the fire drill ground from a massive heart attack and passed away. 2 weeks ago inside Portland Fire and Rescue, a firefighter, while off duty, suffered what they call a widowmaker, and luckily was close enough to a fire station where they were able to revive him and then get him back. So he went in and immediately had 5 stents put in over the course of 3 days. And so when you look at firefighter health, I believe that there is such a correlation between the call volume and when we get a call when we're at resting heart rate, to go from the resting heart rate to sometimes 2 times the resting heart rate in a matter of a minute to get on the rig and go do what we do. I think that we kind of continue to look at firefighter health and safety, not only from the health side, right, working out, eating correctly, but what is that correlation between busy companies and running calls and cardiac arrests.
100%. Yeah, we have all of that heart rate data, and that is one thing, and we have all of the call time. So that is something that we're looking at. That's one of those things that just takes much more time. But yeah, no, that's definitely on our minds as well.
Thank you.
Leandro, you asked, the changes in schedule had a greater effect to be more alert to answer the call or during the action. Are you saying is the response greater on the new schedule? I don't know if you were able. I think that's the question.
I just read the question. I absolutely understand it. I think the important thing is when you do work a 1-3-2-3, because that one in the middle, right? The 1 day in the middle, that is it feels like a very short shift because it's sandwiched by 3 days on either side. You are alert for longer in that 48-hour block when you come back. So definitely the response and the morale, and I think the compassion fatigue that we experience when we go on calls, especially with the rise of the house's population, it's important that we're compassionate on every call. And so having this schedule has dramatically affected that, but also having the ability to do some of our tasks on day 1, which frees up time on day 2, where then we can find the opportunity to have a 20-minute, safety nap, or, that the restoring cycle nap, which we like to call it, is really impactful. That's why, again, the 1-3-2-3 has really taken its hold amongst our membership.
Do you think that's a station or department-wide approach for encouraging the ability on that second day on shift on the 48 to sleep and to take care of more of the administrative duties on the first day? Or do you think it's selective stations that are doing that?
I would say that it's obviously kind of on an individual station basis, but I would say kind of globally throughout our department, it's been a very reoccurring theme to try to front load that first day with more of your administrative tasks and kind of your required daily obligations. And then we've been able to make some organizational improvements as well on the second day. For example, we used to do what's called an all call at 7 a.m. Basically, it would just be over the speakers in the station. It would essentially wake everybody up at 7 o'clock. Well, we were able to do away with that to allow our members to have an extra hour of sleep on their second day of work. So that was kind of a big boost in terms of the efficiency our members were able to have that second day. Also, with emphasizing that work on the first day, we're able to free up extra time on day 2 to exercise or get a safety nap, as Travis kind of alluded to earlier.
I don't know does anyone know if this is the similar case statistics for the police? I know they don't spend time at a place, but our police just got off at 2 a.m. and had to come back at 10 a.m. The police work a different schedule. So they work 10-hour shifts, and so it's different. So they're also severely understaffed right now. So at least in Portland, so it's not like directly applicable. Does the audience have any other questions? Oh, I also want to ask a question about street routes. So that's also it's not even a new initiative anymore. It's been about 3 years, I believe, that they have been available. I know they started as 3. Is it more like 20 individuals now? Have you felt that has reduced call? Do you feel that that's had any impact on maybe some of the homelessness issues, the low acuity calls?
You want to tackle that one, Trav?
Yeah, I think, with the addition of the Portland Street Response and the addition of the Community Health Division, which has extra response for the chat cars, which we call them, which is a low acuity call. There are really starting to pick up a portion of the call volume that allows the firefighters to stay back in the station. So it's definitely working. I know that they're always working on some continued funding for that program, and we are hopeful that they find that continued program, the funding for the program. But it definitely is making a difference. So.
I would also say, I know we had a member from Portland Police on here earlier, specifically with Portland Street Response. Some of the calls that they deal with not only touch in our kind of area of work, but I believe the police as well. So I would assume that it's also reduced their call volume as well.
And I think Travis, you mentioned like the number of low acuity calls are still on the rise. I think Albany was earlier this year, and if I could find it quick, I could pull it up. They had, at least on their Facebook, like a little, I don't know if it's a public health campaign, but trying to teach the public how to better make use of the 911 system, to the point where they'd have a picture of, if you get bit by a hammerhead shark, then call 911. If you hit your thumb with a hammer, go to urgent care. Is there any effort like that with Portland to try to get better use of the 911 system?
We would love that. But at this point, I don't know if we have the budget for that, but we would love an educational thing. Like even just the fact that when your carbon monoxide alarm goes off, if you turn it over and it tells you how many beeps and what it means, and 5 beeps is out of service. And so the companies continually go on carbon monoxide alarms that they're just, the battery's dead, and so even if we did something like that, that would probably take 1,000 calls out of the city a year. I mean, it's pretty significant, but that's okay. We're there to serve the public in capacity. Some education would help out as well.
Yeah, I think public health campaigns that could reduce those calls would be useful, because you want to make sure you're ready to respond or available. If you're out on that kind of call and an emergency comes in, that's less that may be available. So it's important to think of other ways as well. Yeah.
I think it would be fantastic if we were able to do a public campaign to educate folks on the use of the 911 system. I think if there is any education that's occurring, at least in our city, it's done by the individual members who are responding on these low acuity calls, basically educating the people on how to properly go about handling these issues. And as firefighters, we're can-do people. So we're going to show up and we're going to help, regardless of if it maybe is an appropriate use of the 911 system. But we also have an obligation and a duty to explain to folks, the proper use of our services.
Okay, so I'll let this be the last question from Leslie. Has the introduction of 988 a year ago, the mental health crisis line, reduced 911 calls?
Cameron, I'm not familiar with that unless you are.
I'm not familiar with it either. All I can tell you is that our call volume has stayed the same over the last 3 or 4 years. So we haven't seen a significant reduction. So I guess without knowing specifically, I would say there's been no real effect.
Nicole, because
Yes.
the 988 number, everybody should actually be aware of. It was implemented a year ago, and it is a national number, and it's supposed to be basically used very similarly to 911, but for mental health crises. And so our local, for example, Lines for Life is our local mental health crisis line, and so any call that goes in goes to the local crisis line. So wherever somebody, it basically is based on area code, and the data are showing that the calls are answered pretty much now about within 1 minute, 1 to 2 minutes. So this is clearly something that everybody should be aware of, and it should be very for firefighters especially, it should be at your fingertips. So really glad that we're talking about this now, because I don't think there are data out there that are studying yet if it alleviates the 911 calls, but it is supposed to ultimately, I think, do that.
Thank you.
That's fantastic. Thank you for bringing that forward.
It's amazing. It's fantastic. And hopefully everybody everybody will soon learn about it. Whenever I give a talk and I mention it, most people haven't heard of it. So it's taking time to get disseminated. But.
Thank you, Leslie. All right, well, that concludes our session. So thank you again, Travis and Cameron, for taking the time to join me today and for all of your efforts over the last few years now.
Thank you.
Thank you. I know our members really appreciate all the work you guys have done. So it's an honor to be here.
Thanks.
Thank you, Dr. Walls, Cameron, and Travis. This is great. It's really an example of how research can affect practice in the real world. So thank you very much. Our next speaker is Dr. Andrew McHill. Food is really a social construct, and he's going to speak about impact of working, eating, and sleeping around the clock on health and well-being, primarily in sort of shift workers. So Dr. McHill graduated with a Ph.D. in integrative physiology with a specialization in sleep and circadian physiology from the University of Colorado at Boulder. After graduation, he completed an NIH-funded postdoctoral fellowship at the Brigham and Women's Hospital and Harvard Medical School, and then joined OHSU's Oregon Institute of Occupational Health Sciences as a visiting postdoctoral scholar. In 2017, he became a research assistant professor within our institute, and then in 2021 established his own laboratory, which is called the Sleep Chronobiology and Health Laboratory within the OHSU School of Nursing. He serves as an assistant professor there. Dr. McHill is interested in understanding the contributing mechanisms by which mistiming of behaviors, for example, shift work or jet lag, and chronic insufficient sleep, how do those factors lead to adverse health, poor cognitive outcomes. So please join me in welcoming Dr. McHill. And Andrew, I can see your slides, and over to you.
Thanks, Rob. Can you hear me okay?
I can, yeah.
All right, great. Well, thank you for the invitation to speak today. And I will be, as Dr. Thosar mentioned, switching gears a little bit, talking about working, eating, and sleeping around the clock in regards to health and well-being. see, there we go. And so I'm going to start by talking about some of the basics of the internal biological clock or our circadian system. And I know Dr. Czeisler did a great job of laying this out, and it's been discussed a couple of times, and Dr. Emens as well. And then how shift work disrupts this clock, and then move into how the circadian clock, energy metabolism, and health change while in the laboratory, or some of the observations we've made in the laboratory. And then shift to look at how the timing of eating, shift work, and health and well-being look like in the field. So I try to, in all of my studies, try to walk in 2 different lanes. So I try to do pretty tightly controlled, in-depth laboratory investigations, and then also try to keep an eye on more generalizable real-world scenarios. And so I'm going to touch on both of those today. And then last, I also want to focus on how practitioners and people actually doing this work can use this information, because I think that is ideally the end goal of everything that we do. And so, as has been alluded to earlier by Dr. Czeisler and Dr. Emens and others, that humans have evolved this internal biological clock to promote certain behaviors, such as wakefulness, eating, activity during the daytime hours when the sun is out, and then other activities such as sleep, inactivity, and fasting during the night when the sun is away. When we do these activities in this regard, and it aligns with our physiology, which I'm showing here as the curve or the production of the hormone melatonin, which is produced by the pineal gland and is high during the biological night, and then decreases and is low during the biological day, and then increases again. So when sleep is initiated, when melatonin is high, and work and school and social activities occur when melatonin is low, we call this a circadian alignment, because our behaviors are aligned with our physiology or how they're promoted. However, with the invention of electrical lighting, humans have the ability, with the flip of a switch, to extend our work and social and our eating habits into the night when our physiology isn't prepared to handle this type of thing. And so if a circadian alignment is when our physiology matches with our behavior, then we can define a circadian misalignment when our behaviors are misaligned with our physiology. So we are trying to work or go to school at times when our body's prepared to sleep, and then we try to initiate sleep, and this was touched about. It was one of the best explanations I've seen of it from Dr. Czeisler earlier today, of initiating sleep during the day when melatonin is low. And one of the best examples of this misalignment are our shift working population, which entail at least 20% of the working population in the United States. And we know that there are consequences of misaligning this clock. So this is a picture from M.P.A from a couple years ago, where they're showing all the clocks in the body being at a different time because of shift work. And so we know that shift work it results in a 3-fold increase in accidents, which Dr. Czeisler touched on today, and then up to a 25 to 40% higher risk of depression and anxiety, which Dr. Emens touched on a little bit. We also know that there's up to a 40% increased risk of heart disease, and up to a 45% increased risk of obesity. So we know that working against our clock is having, and working and eating against our clock is having all of these impairments to our health. And these are by no means the full amount of impairments that are happening. We know that there are increased risks of cancer, decreased fertility, you name it, you name the disease, and it's probably impacted by shift work. And so today I'm going to focus on these 3 areas, and I'm going to start by just talking about the increased risk in obesity. And so my laboratory has been really interested in just examining how does eating at night contribute to obesity or weight gain. And a lot of times when you're thinking about weight gain or obesity, you think of it as an energy balance equation. So this is just simply if the calories that you consume are equal to the amount of calories that you're expended, or the energy that you're expending, you would be in what we call an energy balance, where you won't gain weight and you won't lose weight because you're eating as much as you're exercising. However, if the calories that you eat are less than the amount that you're expending, so if you're exercising a lot, you start to tip this energy balance into the negative. And if this is maintained over time, then you'll end up losing weight. And the opposite is also true. So if we eat more than we expend, and if we do this for long enough, we'll begin to gain weight. And so what happens in shift work? So we tried to tease apart what was actually happening with energy expenditure shift work by doing a simulated shift work protocol in the laboratory, which is shown here. It was a 5-day protocol, so day of the studies on the y-axis here, that had the participants come into the laboratory for 24 hours at a time. or for the full 24 hours for those 5 days. And so they entered the protocol on day 1, and we hooked them up to PSG, polysomnography, and all sorts of different other equipment, and then had them go to sleep at their habitual time, and then wake up at their habitual time after 8 hours. And they entered into a protocol that was a constant posture. So they maintained bed rest for the next 4 days. And on top of maintaining bed rest, they were placed in this room that would precisely measure energy expenditure. So we'd be able to measure minute by minute energy expenditure. And because they were in bed rest, we were able to control for their activity. And then we fed them the exact same meals for the next 4 days. So each of these B's denote breakfast, L a lunch, D a dinner, S a snack. And so the B's you see here were all the same, and the L's all the same, and the D's and so on. And so we had them do a baseline day shift schedule on day 2 and go to sleep at their habitual time and wake up at habitual time. And then on day 3, they transitioned into a night shift schedule. So they took a little 2-hour nap, which typically occurs in shift workers before their first shift. And then we're awake and ate across the night and did that for 2 more days on days 4 and 5. And so this way we could quantify by keeping calories consistent and energy and activity consistent, how much energy a person was expending, doing the exact same thing at different times a day. And so what I'm showing you here is the baseline versus night shifts 2 and 3 on the x-axis with their 24-hour energy expenditure, or the amount of calories they burned, kilocalories they burned per day. So at baseline, they burn close to about that 2,000 kilocalorie that you typically hear of as how much you burn a day. But when they transitioned to a night shift, this decreased and stayed decreased across both of the night shifts 2 and 3. And this decrease was about 4% decrease in energy expenditure when we controlled for activity, so they weren't just moving less, and we also gave them the exact same meals. And so from that, we conclude that working a shift work schedule and eating at night can actually decrease your total daily energy expenditure. And if you were to do this long enough, so if you were a chronic shift worker, this could start to tip your energy balance into that positive and lead to weight gain. And these decreases, even though 4% might not seem like a lot, they were a decrease of about 217 and 247 kilojoules per day, which are important or meaningful because about 209 kilojoules per day can actually explain the obesity epidemic. So we think that this, all taken together, could be contributing to weight gain over time in shift workers and lead to that increase, up to 45% increased risk of obesity. So that's really tightly controlled in laboratory settings, but what's happening in the real world? And how does eating impact our body compositions or our body fat percentages? And so we did a 30-day study looking at eating behaviors in real world settings. So this is a diagram of the one particular participant's 30 days in a protocol. And this was an outpatient protocol. So day of the studies on the y-axis and time of days on the x-axis. And each black bar denotes the time which they went to sleep for each of these days. And then this blue hatched bar represents a time we brought them into the laboratory where we could measure their body composition. And then the orange bar represents a time which we had them track everything they ate or drank. And so they kept a daily sleep-wake diary and wore an actigraphy monitor to measure sleep. And then they had that one night in-lab assessment for measuring melatonin and also their body composition, and then completed that 7-day food diary. The food diary we used was a cell phone application where we just had people take pictures of everything they ate or drank while they were on the study. So we noticed that people were doing this anyways for Instagram and other reasons. So we thought, why not turn it into a data collection tool and actually get some information about it? And what was great about this app that we used was called Meal Logger, is that participants could take a picture of their meal, which is shown here, and then identify which type of meal it was. So breakfast, lunch, dinner, snack, and then add a detailed description if needed to help the dietitian score it for what was in the food. So this would come in handy if you were eating a burrito and you couldn't see what was in it, even though you took a picture. And so you could put what was in the burrito. And what was also neat about this phone application was that it stored the meals as soon as they hit send to an online database where our dietitians could score them for calories and content. So if there were carbohydrates, proteins, fats in the meal, we could look at all of that. And so here's an assortment of meals that were taken that participants took throughout the protocol. And you could see we asked participants to use something in the photo that was of a known size. And so this was at a cafeteria of a local college. And so we knew what size the forks were. So a lot of times they would just put a fork in the picture. And so we could see how big of a portion they were eating. And then for something like this with this pasta, they would also add a detailed description of what was in it. And you can see like with the pie, or if there was a canned or bagged food, And then also, if there were a number of things, we could count those as well. And we've gotten more sophisticated with our size. We give them a little measuring tape now, or a little like a card that has a little measuring tape on it, so we know the size now. But we were really trying to hammer this home of use something of a known size in this study. And we think we did a pretty good job because this was one of the pictures taken of a person eating a donut on the go. And so we could tell how big exactly that donut was because of the fire alarm. And I thought it was kind of fitting with our last talk as well. And so when we dig into the data, what we find first, and what we did was we separated the participants that either had a lean body composition, so a lean % body fat, or what would be classified as an overweight or obese body fat composition. And we can look at their percentage of daily calories consumed across the 24-hour day. And if we're just looking in the group of the lean body composition, we see that they're eating basically at all hours of the day. So it's peaking in waking hours, but you'll notice that this number here never gets all the way to 0. And so a group in San Diego has coined the term that if a person's eyes are open, their mouth is open. And we find that in our data set as well. But if we look at individuals with an overweight or obese body composition, we see that they actually redistribute or have redistributed their daily calories to eat more calories later than the individuals with a lean body composition. And it's not a high amount, it's just about 5% of their daily calories. But this could be contributing, based on our other data of looking at energy expenditure, to weight gain and obesity over time. And so if we were to throw these data into a regression model to look at what predictors were of % body fat or BMI, body mass index, we could include things such as gender, the amount of calories a person eats, the % of calories from fat, carbohydrates, and protein, so what a person is eating, how much sleep they're getting, how active they are from their actigraphy, and the timing of their calories, so what time they're eating. We put these into a model. The only two things that predict their % body fat are their gender, because females tend to have a higher percentage body fat, and the timing of their calories. And so just to summarize shortly, we find that it's not only what or how much you eat, but when you eat may be just as important to body composition. And actually new therapies can actually take advantage of these findings and have been taking advantage of them. And I'll get to touch on that at the end. So that was obesity. Now I'm going to switch gears to looking at this up to 40% increased risk in heart disease. So what are driving these increased risks of cardiovascular disease? And to get at these type of mechanisms, we have started to leverage, or we have been leveraging, a current hiring patterns in a transportation service in the local Portland area as a natural experiment to identify how schedules impact health. And this has been a study done in collaboration with Drs. Ryan Olson and Dr. Steve Shea, where we're taking advantage of new hiring patterns, especially in the bus operating, and especially in bus operators. Because when bus operators are newly hired, they are trained during the daytime hours. But then because they're new hires, and so we can treat this daytime hiring pattern as a baseline day shift schedule. But because they're new hires, they get some of the, what we consider some of the worst shifts. So they get either the really early morning shift work schedule or a late evening shift work schedule, or both. And so what we've done is we've tracked participants as they are newly hired and are in a baseline day shift schedule, and then what changes in their behavior as they become a shift worker at 30 days and 90 days of working that shift work schedule. Now, what's really nice about this paradigm is that we're able to track an individual within themselves to see how behaviors and health change concurrently. And we also have some of the lucky few in this industry that stay on a day shift schedule. And so we can actually compare the two groups, so day workers versus shift workers. And one of the things that we've been very interested in is the 24-hour blood pressure patterns of individuals. And in particular, we're interested in their dipping patterns. So shown here is time of day on the x-axis and blood pressure of an individual with hypertension on the y-axis. And we're interested in this phenomenon called dipping, where an individual, when they go to sleep, they have a decrease in their blood pressure that is greater than or equal to 10% of their daytime patterns. And so if someone shows this phenotype, this is considered a healthy phenotype. If someone doesn't dip, or they don't have their blood pressure go below 10% of their waking values, we call this individual a non-dipper. And we know from epidemiological studies that being a non-dipper is one of the best predictors for a future cardiovascular event and premature mortality, more so than the hypertension seen here. And so what we did in our study with bus operators is we fitted them with a 24-hour blood pressure monitor, and we sampled their blood pressure every 30 minutes during both sleep and waking. And we could do this at baseline, 30 days, and 90 days. And what we found, if we look at the baseline day shift, and we look at the percentage of the population displaying a non-dipping pattern, that individuals that are working both a day shift schedule and a shift work schedule at baseline, so they're all being trained during the day, both show hovering around 40–50% of the population are non-dippers, which is what you'd expect if you just grabbed a population randomly. When they started to transition into either being a shift worker or a day shift or continuing on the day shift, we don't see much change at 30 days in their blood pressure dipping patterns. However, at 90 days, we see these robust changes in their blood pressure dipping, the percentage of individuals with a blood pressure dipping pattern, such that 65% of our shift workers turned into non-dippers, making it about 98% of our shift working population that were non-dippers, and 0% of our day shift working schedules were non-dippers. And what was interesting is that when we looked at the things that were causing this or correlated with this non-dipping pattern, we initially thought it would be, just the number of shifts that a person was working. And that didn't seem to be the case. But what seemed to actually latch on more so than anything else was the change in their sleep onset timing variability. And so if we looked at this magnitude of dipping, so if you went from being a 12% dipper to a 7% dipper, became a non-dipper, if we looked at that change and we correlated it with different things, we found that the change in that magnitude was actually correlated best with a change in the sleep onset timing variability. So something to do with their change in their sleep onset timing and becoming more variable was impairing their cardiovascular health. And I know Dr. Bowles talked about this in the firefighters, and that we're going to look into that as well. And so we find that transitioning to a shift work schedule results in a rapid change in overnight blood pressure, and that this change in blood pressure and becoming a non-dipper is an excellent predictor for a future cardiovascular event. And interestingly, this was associated with an increase in sleep onset timing variability. A postdoctoral fellow in my group, Dr. Brooke Schaefer, is actually really interested in how these blood pressure changes are happening or occurring in chronic night shift schedules. And so what she has done is she started to look at individuals working a day shift schedule as compared to individuals working a chronic night shift schedule, so working it for 9 years or more. And what she's finding is that individuals, and these are in nursing populations, so it's a different shift working population, but individuals that are working a day shift schedule are dippers for the most part on average, but those in the chronic night shift working schedule are actually non-dippers and have a significantly different magnitude in their dipping status. And so we're seeing this across multiple different shift working populations, and we're seeing it happen very acutely and being maintained into chronic schedules. So now I want to transition away from the health and more into the accidents and the higher rates of depression and anxiety. And so I want to show you one of our studies that we did in the laboratory, and this was a 32-day in-laboratory study done in collaboration with Dr. Czeisler at the Brigham and Women's Hospital, Harvard Medical School, where participants would volunteer to stay in this laboratory for 32 days, and we could test the influence of time of day and sleep restriction on their performance and also on health. And so this is one of the sleep suites at the Brigham and Women's Hospital where the participants would live, and they'd have their own closet and bathroom and things like that. But we would be able to test their performance both at a computer at a desk and then also immediately upon awakening with a computer that would roll right over the bed. And I always put out this disclaimer that this picture was taken a little while ago and the computers have been upgraded since then. But we could also very tightly control the amount of lighting that they would get. So they would live in actually a dim lighting environment. And importantly, this environment was free of any time cues. And so what we could do is we could study participants around different times of the day, so different hours of the clock, while they were getting either short sleep or a control sleep, which is about equivalent to 8 hours on a 24-hour day. And so we could look at typical patterns of a shift worker and getting the amount of sleep that they might be getting if living out in the real world. So the test I'm going to show you today data from is the psychomotor vigilance test, which is a pretty simple task in which you are just staring at a blank screen with a white box. And when a millisecond counter starts to count up, you push a button as fast as you can. And when you push that button, it records that speed. And so shown here would be a speed of 250 milliseconds. which is about the average for a well-rested individual. And then you would do this over and over and over again for about 10 minutes. Now, if you were to get double this time, so if you were to get 500 milliseconds, we would consider that a lapse of attention. So I'm going to show you the lapses of attention here on the y-axis, and I'm going to show it to you in terms of hours of being awake here on the x-axis on the left, or across time of day. And so this is in the 8-hour group. And you can see that when they were doing the psychomotor vigilance test, they had a fairly stable amount of lapses across hours awake. But if you looked at different times of day, these lapses were lower during the day than during the night, as you'd expect. However, if you were in our short sleep group, which was getting the equivalent of 5.5 hours of sleep per 24-hour day, we see really robust increases in the number of lapses across all hours awake, to the point in which at 12 hours awake, so not really an extended amount of time, particularly with what we've been talking about today, where people are working 12 hours. So this would, this would be waking up and immediately ending your shift 12 hours after you've woken up, which isn't what we're seeing, right? So usually this would be like 14 hours of a shift. But we're seeing 5 times the number of lapses in this individual, in these groups, getting 5.5 hours of sleep. And this is most exaggerated during the nighttime hours as compared to the daytime hours. So now I want to show you some of the subjective data that we collected, in which during each of these tests we asked the participants, how sleepy do you feel right now, or how alert do you feel right now? And so we call this subjective alertness, and we do this on a visual analog scale, where they just have to mark on a line, it's a 100-millimeter line, how sleepy they feel, or alert, which are 2 ends of the line. And so a higher number, which is lower on this axis, means more alert, and a lower number means more sleepy. And so we ask them during each of the tests, and what we find is that even though the group getting 5.5 hours of sleep are performing 5 times worse, they feel subjectively just as sleepy as groups that aren't. And this is happening at all times of the day, but it's, a little higher during the nighttime hours, but still pretty similar. And so other groups have shown this as well during sleep deprivation. The group up at Washington State and Penn have done this. And other studies in Dr. Czeisler's group have also shown this. But this was just during chronic sleep restriction. I think it's kind of striking that it's holding true at all times of the day. So what about that wakefulness, or that grogginess upon awakening, which was also called sleep inertia? And so we put a computer right in front of right on top of their lap, right when they woke up at each wake period. And then we would have them do performance tests every 10 minutes for about 2 hours, or every 10 minutes for 70 minutes, and then another performance test at 2 hours after awakening. And so this was a performance test where they had to match a shape with a number, and they would have to do it really quickly and as accurately as possible. And so just for the purposes of this presentation, a higher number is someone doing better than they did at baseline, and a lower number is someone doing worse than they did at baseline. And so if we look at that 8-hour group again first, we see that they are performing worse than baseline immediately upon awakening, within 10 minutes, about 2 minutes upon awakening, which is what we'd expect. We've seen this over and over again in a whole host of different studies. But these decrements in performance actually dissipate really quickly, to the point where at 10 minutes later, they're kind of right at baseline levels, and then 20 minutes later, they're kind of on their way and going great. And then two hours later, they're doing really well. But if we look at the 5.5-hour group, we see that they perform significantly worse immediately upon awakening than the 8-hour group. And it dissipates in a similar fashion, but they never get back up at the baseline until about 70 minutes after awakening. And then even at 2 hours after awakening, they're still performing pretty poorly. And if we want to put this into context of what these performance decrements are looking like, if we look at just that first test during wakefulness, we find that they are performing actually 50% worse than an individual that be performing a similar task with a blood alcohol concentration of 0.1. And so these are really severe impairments that we're seeing just by getting a pretty common sleep duration that you see in the population. And again, if we look at this during different times of day, this is more exaggerated at night than during the daytime. And if we ask people subjectively, how are they feeling right when they wake up in regards to sleep or alertness, these two lines are right on top of each other. So there's a subjective disconnect with their objective performance, and this could have some pretty severe implications. So just imagine a doctor on call needing to wake up and perform something, perform a procedure really fast, or give information about a prescription really soon. or an emergency professional needing to get behind the wheel of a car to drive somewhere. We also, in this study with bus operators, have been very interested in workplace satisfaction and other items of well-being. And so what we've been able to do during this study is we've been able to ask questions in survey form about well-being and workplace satisfaction, both at baseline and then weekly throughout their 30 and 90 days in this study. And so we can actually track their workplace satisfaction and well-being. So these are the weekly surveys. And then we can do a pre-post at 90 days and baseline to just see how they're doing. And so shown here are 3 questions from a whole big host of questions that we ask in a large survey. But primarily today, I just wanted to focus on, do you like your job? Are you satisfied with your job? And my job produced strain that made it difficult to fulfill family duties. And so I think a lot of these things can be matched really nicely with some of the work that Dr. Bowles have done with the firefighter work and Dr. Emens has shown before. So these are just Likert scales. And so a higher number means that you agree with this question, and then a lower number or a decrease would mean that you disagree with this question. And so you can see that most people liked their job, or they agreed with that, starting it in the day shift schedule, and they were satisfied. And then they didn't think that it had a large strain on their family when they worked their job. But at 90 days of working shift work, or at the furthest weekly questionnaire that we could get from individuals that didn't complete 90 days, we find that people significantly dislike their job, or they don't dislike it, but they like it less than they did. They are less satisfied with their job, and they think maybe potentially it's because it's putting a greater strain on their home duties. And so just by changing the time in which a person is working, it could be putting a strain on work-life balances. And I know that we see this a lot with the firefighters and with other populations as well. And so just to summarize, chronic short sleep, as common during shift work schedules, can result in dramatically impaired performance, particularly at night. And these feelings of alertness, these subjective feelings, are not similarly impaired. And upon awakening, performance is impaired, and this impairment is greatly pronounced when chronically getting short sleep, which can be worse than being intoxicated with alcohol. And then we also know that moving to a shift work schedule can reduce workplace satisfaction. And so I've just shown you a lot of data, and most of it hasn't been great. And so the question is, what can we do about this? And so our laboratory has been working at different countermeasures to try to tackle this, because shift work isn't going away, right? Operations are going to continually be needed 24 hours a day. So how can we make improvements in both health and well-being? And so one of the things that we've been focusing on has been looking at shifting the timing of calories to the daytime hours. And so we know from data that I showed you previously that eating at night, it reduces your energy expenditure and makes you gain weight. So what if we just get rid of the eating at night in our shift work populations? And what if we are to shift those calories to daytime hours? And so we kind of have come about this hypothesis based on data that we collected from our bus operators, in which we expected them to gain weight because they were turning into shift workers. But what was interesting is when we look at the change in percent body fat in our bus operators when they started working their night shift or their early morning shift and their late evening shift. And we looked at that change in body fat percentage with their shift in calories at night. We actually find that there is a significant correlation such that the more calories you eat at night is significantly associated with a higher percent change in body fat percentage. But if you look, if you look more in depth at this figure, you're seeing that most of our participants are actually losing body fat percentage. So they're actually losing weight. And that happens to be the people that are not shifting their calories later, or they're actually shifting it earlier. And so this is just one example of how we can move our calories around or move our behaviors around to improve health. And we also, I just want to highlight that this change in daily calories consumed was not correlated, or is not correlated with body fat percentage. Similar to what we found in previous studies where we looked at individuals that ate later had a higher percent body fat. We do not see any association with our calories there. And so other groups have been more on this than us, or have been more productive in getting this work out, but looking at these ideas of what we call time-restricted eating protocols. And so this was a study done back in 2019, but this group, Courtney Peterson's group, or this Sachin Panda's group actually, was what they were looking at a baseline eating schedule versus a time-restricted eating schedule. So what they did was they lowered the window in which an individual could eat. And so they said you can only eat from like 9 a.m. to 3 p.m. during the day. And they looked at weight, BMI, and percent body fat, and they found significant decreases just by restricting the timing of their calories in the study. This was in overweight and obese individuals. If we look at this in lean individuals, and we look at it as kind of a dose response. So if you're eating a control schedule versus a middle time restricted feeding, so like eating during the middle of the afternoon versus an early time restricted feeding, so eating earlier in the day, we find that there's almost a dose response phenotype that comes out, in that the earlier that you eat, the more you'll have a change in body weight and percentage of body fat. And these studies are also correlated with changes in other health outcomes, such as cholesterols, triglycerides, other type of lipids, and some metrics of cardiovascular health as well. And then last but not least, Dr. Frank Shea at the Brigham Hospital has been looking at this as potentially a countermeasure for shift work. So he has a shift work paradigm where they come into the laboratory and do that simulated shift work schedule, similar to what I showed earlier. But he keeps the calories on the ends, and he's found improvements in glucose tolerance and cardiovascular outcomes. But what he's also found, which is somewhat, I think, a little surprising, is improvements in mood. And so if we look at their depression-like mood here on the y-axis, so less depressed is lower on this y-axis versus more depressed is higher. If you're eating at night, so if your calories shift with your shift in schedule, so this is the baseline, is the black, we see that there's an increase, this orange, the eating at night, an increase in depressed-like symptoms. But if we were to shift a person into this night shift work schedule but keep their calories on the edges, we actually don't see that increase in depressive-like mood. And so maybe this can be something that we can look at, but it really kind of puts it on the individual level. And so it forces the individual to have to make decisions about the time in which they eat to improve their health. And so we're also very interested in kind of at the institutional level what can be done. And that brings us back to Dr. Czeisler's work. And I know this has been talked about a couple times today, but the idea of scheduling around a worker's clock to improve health and well-being. So just if you can figure out where a person's clock is and matching their work schedules to that clock, we could see improvements. And Dr. Czeisler had shown this earlier about putting individuals on a 21-day phase delay rotation as compared to control, or a weekly phase advance. You see that there are increases in the health index, so people are feeling healthier on questionnaires. And then there's also for the employer, they had seen increases in production, so in potash harvest and personnel turnover decreased, and processed potash also increased. So you're getting health benefits, but you're also seeing performance benefits as well. And then in regards to mood and well-being, Dr. Celine Vetter and Dr. Till Runberg back in 2015 published these data in Current Biology, looking at matching an individual's chronotype, or their morning or evening preference. So if you are a night owl versus a morning lark, and if you could work in a schedule that would match your chronotype, what does that do for your sleep duration and then also your well-being? And so what they did was they looked at individuals. They had a company that they worked really closely with in Germany, and they were able to match an individual's work schedule based on their chronotype, but they were able to measure their sleep duration and well-being first before they made this chronotype specific schedule. And they could look at how much sleep they were getting. So you can see the early type was actually getting around 6 hours of sleep, whereas the later type was actually getting more, around 7. Or the early type is getting not enough, and the early 2 and the late are right on top of each other, right around 7. But when they put them on a chronotype schedule, so the late individuals were working more of a late shift, the early people were working more of the early shift, they saw increases pretty much across the board, except for those intermediate types of sleep duration on work days, and then they saw increases in well-being on work days as well, particularly in the individuals in the extremes. So the very late individuals and the very early individuals both had increases in well-being. And so we can see these increases in health, we can see these increases in well-being just by scheduling around a person's clock. And so just to kind of summarize why this work is important and why today has been important to talk about it. As I mentioned previously, about 20% or more of the adults that work in the United States work shift work hours. So they're working before 7 a.m. or after 7 p.m. And this population is not going away, and it causes changes in sleep-wake timing and makes it more variable and more disrupted. And so if we can identify mechanisms for poor health and well-being, what we're doing in the Institute and what I'm doing in my laboratory, such as changes in blood pressure, the later timing of food intake and workplace satisfaction, we can find these changes and we can target them at certain times for intervention. And then, which is kind of what I mentioned here. And so with that, I'd like to thank everyone in my lab, the Sleep Chronobiology and Health Lab, individuals of the Olson Laboratory who've helped a lot with those bus operator studies, and individuals of the Clinical Physiology and Chronobiology program at OHSU and our grant support. And I would love to take any questions. And if anything we don't get to today, please feel free to email me.
Dr. McHill, thank you so much. That was outstanding. We have 4 minutes before we go into break, and there are 3 questions in chat. And so I'm going to go to the first one by Ellie, who asks, how does limiting nighttime calories work for high intensity work like nursing? One can take 20,000 steps through a shift. Any suggestions there?
Yeah, I think it would be more just loading what you were eating predominantly during the wake period. If you can just load it kind of on the shoulders of that shift. So you're eating more when you're waking up, and then you're eating more, so in the evening hours, and then more in the morning when you're going home. And then when you need energy throughout, you can have smaller snacks throughout, but just not having those big meals, in the middle of the night, I think is probably a way to help it.
There is another question from Anjali who asks, can we potentially buffer the effect of nighttime eating by changing the type of foods one eats when shift working?
We have, no one has done a lot of work into what exactly people are eating during this time, and if that can have an effect too on kind of buffering the effect. It's mostly been just focused on the total amount of calories, or just even looking at the timing of calories. So it might not even matter what a person is eating, just when they're eating. But that's an interesting idea of looking at what it is on top of that could kind of ameliorate this response.
Momoko had a question. They asked, if someone changes from night shift to day shift, do these negative effects also change back after some time?
Yeah, so that's what we were trying to look at with those chronic shift workers, and it doesn't appear to be the case. Now, what we see also kind of dose response cases with cardiovascular disease in particular, where the longer that you're working shift work, the higher your risk is for a cardiovascular event. So Dr. Celine Vetter has shown that as well. And so, but what we also might be seeing is maybe a healthy worker effect too. So the individuals that are able to work shift work longer, maybe ones that are able to withstand it a little bit more. And so we could actually be seeing all of these risks, these percentages could be lower than they actually really are, because the people that just can't take it or are more impacted, poor health-wise, may be dropping out of shift work earlier. So we may not be able to see it, but it does seem to get worse before getting better.
Cool, thank you. I had a question. I don't see it. When you find the change in day and night blood pressure pattern in your participants, both acute and chronic, do they actually also become hypertensive, or does their blood pressure also increase during the daytime and the nighttime, absolute numbers?
No, we do resting blood pressure metrics when they come into the laboratory, and we never see any differences in their resting blood pressure. It's just this dipping pattern, which I think could point to kind of why it could be a really great predictor for future cardiovascular events, more so than just resting blood pressure values that we see when they come in. But it's a great question, and it's interesting.
Thank you. We have 1 more minute, so if anybody has any question, maybe one more question. Sorry, I'm just trying to keep everybody on time, that's all. But this, I mean, we could go on for, it's a great data here. Okay, hearing none, Dr. McHill, thank you very much. This was great. We are going to go into an 9-minute break. It's 2:09 in my clock. Let's come back at 2:18, because then we have one lecture, a breakout session, and then we'll conclude at about 3:30 on time. So thank you again. Keep yourself muted. You can turn off the videos. See you back at 2:18 p.m. Okay, everybody, welcome back. It is 2:18 in a few seconds. It has been a fascinating day so far. And so during the last part of this day, we are going to focus on workplace strategies that support workers who are working shift schedules. And we've learned a lot of, what difficult schedules do. We've also heard a lot of tips. And so the hope is to consolidate all those and distill the ideas in the last 7 10 minutes that we have. So to begin this session, Emily Bergkamp, who is the interim general manager of Intercity Transit and M.P.A, is going to speak for about 15-20 minutes. Then we are going to go into breakout sessions. Participants will be randomly assigned to them, and each session will have a facilitator. And then the idea is to have all those consolidate all those ideas in a big group session again at 3 o'clock. Then we'll go from 3 to about 3:20, and then we'll conclude for 10 minutes. For the next session, I'm going to ask or invite Dr. Ryan Olson, who's a professor at the Oregon Institute of Occupational Health Sciences, and he's also the co-director of the Oregon Healthy Workforce Center, to introduce Emily Bergkamp. Over to you, Ryan.
All right. Thank you, Saurabh. So it is my pleasure to introduce Emily to you all. I have met and gotten to know Emily over the past several years as her partner in a bus operator project focused on supporting their health and job success as they get started. And I was really struck by Emily's thoughtfulness and her caring orientation for her employees in general, and in particular for the bus operators. So Emily started her 20-year career at Intercity Transit as a van pool coordinator and has risen through the ranks to now be leading the whole agency. And she has a background training in public administration. She also maintains a Class B commercial driver's license, which is going to further help her empathy for her people, and has been involved in additional training with the American Public Transportation Association, graduating from a leadership program from that association. So I won't take any more of Emily's time. I'd love to hand over the baton and let you all hear from her.
All right, and hello everybody. I'm going to switch this into presentation mode, and Ryan, if you could tell me if that's in presentation mode, I would appreciate it.
It looks like presentation mode for me. I'm seeing both your video screen and Mitch's video screen, but I can minimize those. Yep.
It's perfect. Awesome. Great. All right, well, we'll go ahead and get started then. So yes, welcome. Thank you, Ryan, for that great introduction. And it's been fabulous to work with you this whole time, especially trying to troubleshoot a lot of the issues that arise when folks are working very taxing jobs and long hours, shift work early, late at night. So as Ryan mentioned, I'm Intercity Transit's interim general manager, and the topic of my presentation is how to nurture a culture of wellness, which I think that we make great strides for every day here at Intercity Transit. We certainly are a work in progress, but there are a few things that I think we do particularly well that I thought would be helpful to share with this group today. So a lot of folks don't set out in life thinking, I'm going to work in public transportation. Usually those of us who work in this industry, public transit finds us. And honestly, how public transportation found me is I started out as a volunteer on our community advisory committee. So it was a volunteer position. At that time, I was working in an adult daycare center doing social work, and a lot of our clients rode public transportation to get to our program. But when I was volunteering on that committee, I realized how much everyone appeared to really like it working at Intercity Transit. We're located in Olympia, Washington, which is the state capital here. And I thought, you know, if there's ever a position that comes open there, I'm going to apply for it. And I did in 2004, became a van pool coordinator, as Ryan mentioned. And fast forward to almost 20 years later, I haven't regretted a moment of working here. So I'll jump right in. So I really feel like creating a culture of wellness is a combination of things. And it certainly hasn't happened for us overnight, especially in the transit industry where we operate nearly year round at all hours of the day and night and in all conditions. But we found that having transparent hiring practices followed by excellent training and a healthy dose of inclusion helps us stay transit strong, as we like to say. So in the next few minutes, I'll review how each of these plays a role in our culture of wellness. So I personally believe, as most of us do in our industry, that diversity is really important. I specifically believe in public transportation because we serve everyone out in our community. We're also a zero fare system, meaning that we do not charge a fare for people to ride. So I think diversity in our drivers is really important because they should reflect the community that we serve. But at that same time, we also make it really clear in the hiring process that we're looking for people with excellent customer service skills. So we found that we can teach most everyone how to drive a bus, but you can't necessarily teach those soft skills like great customer service. One of the important things in transparency of hiring bus operators is that they really need to know, even starting out, is that the hiring timeline to become an operator or a bus driver is really quite extended. And so from application to start date, it could take up to 8 to 10 weeks. So it's not really ideal for those who need a job immediately. But some of those things that are included in that timeline is obviously applying for the position. We do a customer service test, which kind of gives us a reading on just how folks would handle a diversity of situations and how they would respond to those situations. Definitely then there's the interview, as well as after that, they also need to complete the initial testing for their CDL permit. So more recently, we've been trying different ways to shorten that hiring timeline, because unless you are moving from one job to another, if you don't currently have an employment, it would make it really difficult to wait that 8 to 10 weeks to become an operator. But recently, especially COVID has really challenged us to change the way we do things in many areas. But specifically in hiring, we have recently tried to partner with agencies like WorkSource. So WorkSource is a statewide partnership of state, local, and nonprofit agencies that provide an array of employment and training services to job seekers and also employers like Intercity Transit here in Washington. So what we did is we did a one-day hiring event where we really check off all of those different stages of becoming an operator in one day. And it was very, very successful for us. We ended up hiring a class of about 20 bus operators that particular day. So here is a flyer from that event. And really, we went through the application, the customer service test, if people had time to complete it that day, along with the interview and a practical fit test. And practical fit really, we go through a variety of some of the physical things that people would need to do during the course of their day as a bus operator. And I think really being transparent with people about what is needed as part of this career path is really important. I think the more people know up front about the job they're getting into, the more likelihood they are to make that decision eyes wide open, which is really does contribute to that culture of wellness that I was talking about. So again, we try to be really transparent about what the realities of being a bus driver are. So this is a represented position. The union that represents our bus drivers is Amalgamated Transit Union. And so jobs are based on seniority. And really what that means when we're trying to tell people about what they're getting into is that, you know, this is a job that has non-traditional work hours and days off. It could take several years to get to a traditional weekends off due to jobs being bid on by seniority. For example, our what we call Transit One, our bus driver, Dave Rude, he's been here for 41 years. And so Dave probably has access to those 410 schedules with those long weekends off. And again, time off is by bid as well. So they have to bid on their vacation time, which means they may not necessarily be home for the holidays when they're a newer operator. So we really try to be transparent about that information when people are even just applying. Also, we have a position called the extra board. So our extra board drivers they really only bid on their days off. So today at 4 o'clock, they will find out what they're doing tomorrow. They know what their days off are, but they don't always know what they're doing the next day. And we really need that as a necessity in public transportation to be able to provide that lifeline service to the community. We need to be able to cover people's vacations when they call out sick and a variety of other issues that kind of come up. So the other unique thing about working in transit that we try to be really transparent about is split shifts. So most transit schedules are scheduled around a morning and an evening commute peak time. So that means that someone might have a 4-hour unpaid split or break during the course of their day. And some people really enjoy that. They get to, go home, pick up kids from school or go to the gym, run errands, go to the doctor. But other people, that's kind of a deal breaker for them. So again, we try to be really clear about that. The current starting wage, too, under our collective bargaining agreement with ATU right now is $23.43. So just thought that I would share that, too. But after we kind of go over those types of things, and honestly try to scare people off, because we really want people to go in, fully knowing what they're getting into, we really get to talk about the benefits of working in inner city transit. So again, we have a wonderful sense of community, and I'll kind of go into how we've built that here. We really kind of talk about our culture here is almost like a family. Again, we have wonderful state pension. We are what's called a public transportation benefit area, so we do have access to the state pension. We have a great 401k and 457 options. We also think people get a lot of personal fulfillment from being ambassadors to the community as bus drivers as well. So we really try to share that. And I always refer to operators with a capital O. I think they're one of the most important assets that we have here. And I never want them to feel like they're second-class citizens, because really they're the first people that everybody sees when they hop on the bus. And in fact, when I tell people I work at inner city transit, they usually ask me if I drive the bus. And that gives you a clear indication of how most of our community thinks, like, well, you have to be a bus driver then, which is perfect, because they're the most important piece. I'm going to share just some glimpses of our culture that we also use in our hiring promotional materials. These are not actors. These folks did an amazing job just sharing their thoughts on what it's like to work here.
When I started, I didn't have a CDL license. I got my permit, and the trainers were excellent. They definitely helped in every aspect to get us to learn all of the parts to the vehicle, all of the parts of the test that we needed to know. They wanted all of us to succeed.
Everybody has been very supportive. They've all been there if I had a question. And that is not common in a lot of employers. So it was such a welcoming atmosphere.
I became an operations supervisor about 4 months ago, and when I did, I went through about an 8-week course as well, learning the different roles of dispatching to being on the road, making sure our buses can drive safely and smoothly with detours. Ample opportunities for internships to try the different fields, so you don't have to leave your profession to try something out of the blue. You can try it for a few months, a year, 2 years, and then come back to your initial field if you didn't like it. Or they can see if they like it, and then the next hiring opportunity, they could be hiring you for that position that you already interned for.
The very first time when I was on my own, it was like, am I really doing this? It seemed a little bit surreal. When you're out there driving, you're out there by yourself, but yet you're not. You have the support of dispatch. If you have any issues or questions or need clarification, you can always call them and ask for their assistance.
Our dispatchers support everything that we do. If you have any questions or concerns, I don't hesitate to call them, and they are truly there for us all the time.
Going from serving the United States through the Army to serving the local community through interstate transit. There's all kinds of different opportunities that interstate transit provides, and there's so many different kinds of internships and possibilities for people to find your niche to help the community. In interstate transit, it's a very great supporting group of people that work here.
The operators are my family. Intercity transit is part of my family. I'm kind of married to them now, and the people here are everything to me.
If you want a stable job with great benefits that is always going to have a need, being a transit operator is a great place to be. We're needed. People generally appreciate us. It's a great place to be, and the pay benefits are just a bonus.
And then this is just a glimpse of kind of our family environment. This is our Transit Appreciation Day that we have every year.
Intercity Transit is family-oriented. We support each other, and we're dedicated to co-creating a great work environment that spreads to not only our employees and their families, but also to the community we serve. We love working at Intercity Transit, and you would too. Come join our team.
All right, so we've covered kind of the hiring practices and just being super transparent about it, what it's like to be a bus driver. But also, the next big thing for us is training. We have an 8-week intensive training program, and it's fully paid. We do let people know it is intensive, so that first 8 weeks, they are going to have built-in overtime into their training. They may not see much of their family members during that time. But we also try to balance that with providing some meals for them during this time, and also just making sure they have the support they need, you know, to get a good start here at the agency. So, and for us, 8 weeks is more than just getting their commercial driver's license and passing that test, even though that's very important. We always want to make sure they feel a part of our culture. They get a big agency overview. We really focus on telling them that it's about safety, service, and schedule. We really want safety to be the first thing, including their own personal safety and whether or not they feel fit to drive. We go over proper ergonomics in the cockpit of the bus. We also talk about human trafficking and some of the difficult things they might see in their day-to-day experiences, how to manage fatigue, also other driver distractions, as well as de-escalation. So we really try to cover a wide variety of topics, more than just what it means to drive a bus. Next is inclusion. We really feel strongly that our frontline workers need to be heavily included in everything that we do as an agency. So they are definitely big participants in the committees that we have, our wellness committee. So again, our culture of wellness, we have a committee that's dedicated to just that and promoting wellness among all employees. Other committees, one that I would point out is our Run Cut committee. So we have a planning department that puts together jobs and shifts for our operators, but we found that while it's important to meet the needs of the community with public transportation, we also want those jobs to have a work-life balance. And so we have operators that serve on that committee, because it's great to have great service in the community, but if you have miserable operators who are super tired all the time because they're not getting, you know, the type of breaks that they need, we want to make sure that they're included in building what their pieces of work look like. And then also our Joint Labor Management Committee, it's really important for us to have good labor relations with both of our unions. We have ATU and also IAM. More about investing in health, I've included some pictures here of our employee gym, which is 24/7. We joke that we're 24/7 fitness, but we do have a graveyard shift and maintenance, and it's really important for them to have access to a place to work out, you know, during their shifts. We also have a quiet room where folks can go and take a nap if they'd like to, and have a power nap as we teach them. That's the best type of way to kind of rejuvenate themselves during the day. But other ways of inclusion, we do have a lot of employee recognition. We always make sure to recognize operators when they've done a great job. They have tough jobs out there sometimes, and so they need to know how much we appreciate them. We have Wall of Fame, which is kind of our Employee of the Year, as well as our Transit Appreciation Day. We have a holiday banquet. We do like to celebrate. A couple other things that I think really helps folks feel included as operators is that we do offer tuition reimbursement. So if folks have, you know, arrive here and they see other aspects of the transit industry that they're interested in, if they go back to school and study topics that would be related to public transit, including I went back to school for my M.P.A. degree as well. We would do tuition reimbursement for that, as well as we have internships. I think in that original video, one of our operations supervisors, Gavin, talked about, he was able to do a operations supervisor internship, which gave him a little bit of a taste of what it might be like to have that position. And then it also helps them be more competitive when we do hire for those open positions as well. And then last but not least, I think that leads us to being transit strong, which is kind of the comparison that I would have for a culture of wellness, is that we're transit strong. And COVID did definitely change this. I talked to Amy early on as we were putting together this presentation, is that I think one thing that we've learned is, we were kind of like the post office. Like, people showed up, rain, sleet, hail, sun, or snow, and so a lot of folks always felt pressure to work through sickness. And I think one thing that COVID taught us is that we could no longer do that. You can't tell people to encourage working while you're sick. That's something that just doesn't fly anymore after COVID. And honestly, when I look back, before I became the interim general manager, I was the operations director. And I can think of times when we probably shot ourselves in the foot, honestly, for encouraging that, because then you're just sharing whatever that bug is, whatever that virus is, and then it takes down, 15 people. And I think that is an important lesson that we learned through COVID, is to be balancing that and not encouraging people to work sick. You always worry about people taking advantage of that, but I think that we've learned through COVID is that we can make it work. So this is a picture of one of our operators who kind of transitioned during COVID to help sanitize buses as we kind of reduced some routes. We never laid people off. We were dedicated to maintaining people because, as you know, investing in people and helping them get their commercial driver's license and all the training and time that we've invested in them, and what a great investment they are for us as being out there serving the community. We didn't want to, just take that lightly. It was definitely important for us to maintain people and employment in here at Intercity Transit. So that was a super thumbnail sketch, but those are a few things that I think have really helped us as an agency focus on creating a culture of wellness here. Is obviously just being really clear with people as they're applying for the job, trying to focus on training more than just the commercial driver's license, and people make sure that they understand this is much more than just driving. And then lastly, just inclusion, making sure that our frontline workers, and that would extend to our maintenance staff as well, is that they are really integral in the committees that we have so that they can help shape this culture of wellness that we enjoy at Intercity Transit. So with that, I'll stop sharing and just thank you for your time.
That was great. Thank you, Emily. So I think we are going to be put into breakout rooms now. Someone is going to do that, correct?
Saurabh, before we go into breakout rooms, I might just suggest, since Emily hasn't had a chance for Q&A specifically, if anyone has questions for Emily,
good point,
I'm guessing they could, if they put them in the chat, we might be able to send a few of them to Emily by email if she wouldn't mind answering. Because I do think, based on time, we might need to go to the breakout rooms. Emily, would that be okay if you had a few questions by email?
Totally fine.
But Ryan, you're right. Maybe we could take a couple of minutes to maybe take a one or two questions if they're burning. If you had a question, for example,
That's a good question, if that's okay. Oh, there's a question in the chat. Why don't you go to the question in the chat and then I'll ask after.
I see a question from Momoko asking, do you have a pre-employment physical testing?
We do. It's called a practical fit test. And what that looks like for us is we have a 40-foot coach and then also one of our body on chassis cutaway vehicles. And we have folks just walk through adjusting the driver's seat, the steering wheel. They also practice getting down on one knee, for securing mobility devices like wheelchairs and scooters and things like that. So, and I can provide you more detailed information on that too, Momoko, in a separate message too. So, yeah. Any challenges still in our organization? Definitely. I'd say right now for us, it's trying to get back up to full service. So we're really consistently hiring for not only bus drivers, but other positions too. And things are starting to loosen up. I think most of us here can probably say that it seems like things are starting to change with hiring, and they're not back to normal yet, but they're getting there. And so that's still the biggest challenge for us, is trying to get back up to full service as a community while not lowering our standards for hiring operators with great customer service skills. So, yeah.
There's one more question. Maybe we should take this last, and I think Leslie had a question after that. How do you address mental health and reducing stigma?
That's a great question. We really try to promote our EAP services. We actually, through Washington State, we use the same EAP service that they have for their employees. So, for example, last weekend we had a really bad bus accident, and we don't have those often. It was not the fault of our bus driver, but they did an amazing job avoiding the accident. That would have been a head-on. It was a head-on collision, but he mitigated it by making some great maneuvers to avoid it. And what I noticed that brought up for a lot of our drivers is, you tend to have a false sense of security when you're in a vehicle that big, thinking, I'd probably come out okay if I was in a serious accident. But we saw through this collision that that's not necessarily the case. The driver was not seriously injured, but there was significant damage to the vehicle. And so I made sure to send out a message to all staff just about our EAP services, because it really does get you thinking how quickly your life can change in the event of a traumatic accident like that, especially when you're a professional driver. So we definitely try to promote EAP. And then we also have a lot of wellness activities. We've done meditation in the past. We focus on mental health wellness as a topic to try our best to destigmatize that, because you're right, it's difficult. And we definitely want to do our best to make sure people know where their resources are.
Dr. Hammer, you had a question? I think you said that.
I'm going to let Amy go ahead, and I think she wants to move us into the breakout group. So I will refrain.
Okay.
Thanks, Leslie.
I think we're back in the main room, everybody?
Yeah, I think we're back in the main room.
Okay, yeah, sorry that you were cut off, Dr. Czeisler.
That's okay. So, Erin, are you still there?
Yeah, I am.
All I would, just to finish that sentence, was that I think that's one of the reasons why I believe we are at a special moment, and why I said in the earlier general session that I think that the time is ripe to take advantage of this awareness and to begin to implement some of these changes.
That's great. That's a good aha to report out on.
Okay, so I think we had 6 groups from what I could see on my thing, and so if anybody wants to share something that we had a lot of thoughts that Ryan wrote down. Anybody wants to share something that they distilled from today's session? Dr. Hammer, do you want to mention about, I remember I emailed you about your your strategies and interventions in soldiers and how you take research into real life practice.
Yes, actually, I'm going to put a link into the chat. Hopefully that link will work. And I just, in the area of sleep, while I am not a sleep scientist, I know many, and I have included many as collaborators on my research projects that have focused on developing training for supervisors and managers on how to better support employees, and then measuring that training effects on employee psychological health and well-being. And what I have found over and over again is that, first of all, that when we train managers and supervisors on how to support employees around like work-life integration, that my work with the Work, Family, and Health Network that F.A.B.S.M worked on, that Ryan also worked on, and we had actually many institutions and collaborators. We found that when we developed and evaluated a training that reduced the work-family stress for managers and supervisors, that we actually impact sleep health of their employees, because the managers and supervisors had more resources and they were able to treat their employees better and communicate with them better, and they helped to alleviate the stress. And that led to reduction, improvements in sleep. And we even found improvements in sleep time. So it was self-reported sleep, but it was also actigraphic sleep. And that was at like 6, 12, and 18 months down the road. It was pretty amazing. And in another intervention study where I actually trained supervisors on sleep health, and that was with Dr. Shea and Dr. Crane and others, we trained supervisors in the Oregon National Guard on really how to understand sleep health and how to support sleep health of their full-time members in the Oregon National Guard. And again, we measured that with actigraphy and with self-report, and we found that that training, that education and information impacted the sleep as well as other psychological health outcomes of their employees. And so it can move, and I have a lot of thoughts after today, and especially I was very excited after the morning keynote address that we here at the Institute have all of the resources and the knowledge and the scientific knowledge and the outreach to actually develop what could be a very important intervention around sleep education for not just employees, but for managers and supervisors, and how we integrate the in-depth information on sleep along with the knowledge around how to train managers and supervisors. So stop there, but it was very exciting for me. The whole day has been very exciting for me. So thank you.
I'm happy to report out from our group, Saurabh, if that would be helpful.
Yeah, go for it.
Okay. Hi, everyone. I'm Erin Flynn. I'm the Outreach Director at the Oregon Institute of Occupational Health Sciences. I think there were two important sort of ahas from our group, and they actually relate well to what Leslie just shared. We had an individual in our group who has spent 23 years working a swing shift, and he shared the impact that that's had on his life and his family in particular. And he said what was probably his biggest aha today was that he didn't realize that there was all this research on sleep, and it resonated. It was consistent with his experience, but he doesn't have access to the research and the solutions and all of that. So Leslie, to your point, I mean, this is a really great example of how do we move the research to practice, and how do we package it for the people who could benefit from it? So that was sort of an aha from our group that I think is motivating for those of us in outreach. And then the second was this idea that, you know, sleep is having a moment in the culture, that there's an awareness, there's a growing awareness, a much greater awareness, perhaps as a result of the pandemic. We don't know exactly why, but a growing awareness, and I see it daily just in the popular press, about the importance of sleep to health and mental well-being. And so to the extent, again, that there's greater receptivity and interest in this issue, it is a moment for sleep researchers and sleep practitioners, you know, to really try to communicate this work in a way that people can receive it. So those were sort of two interesting things that came out of our discussion.
Steve, you have your hand up.
Well, if there are no other questions at the moment from others, I want to report out on a special breakout session I had with Professor Charles Czeisler before we went to our other group. There were just the two of us in there, and well, we were enjoying it. We got sent out to different panels, and I'd asked Chuck that we obviously need to educate the management. We need to educate people. We need to educate clinicians about sleep and the importance of the right protections for workers, etc. And also the individuals, without putting too much responsibility on the individuals, recognizing that individuals have different responses and needs, and their families' needs as well. And Chuck said AI can possibly help us with this, and I was about to say, we definitely need something like AI, because I can't even solve the jet lag problems of my neighbors when they fly off to Beijing or England or whatever, because I have to tell them to control their light intake, the timing of their sleep, and the likelihood of their not sleeping, and what to do when they don't sleep. Don't get exposed to light at the wrong time, because you'll shift your clock at the wrong time. And avoid light when you get there, and go to bed at certain times. And there was like a 13-point discussion that I had when there were some kids who were going to play them in a concert, and they're going from Portland to Beijing, and getting them to put dark glasses on, get bright light at certain times, stay asleep in the middle of the flight, and then open the windows on the plane, and you don't know what lights are going to be on the plane. That's just a simple jet lag protocol. So of course, I'd love if there was an app for that, and there are some that attempted it, but it really has to be tuned for the individual. And I think it's almost beyond, it's difficult. So maybe AI can come into this. That was an aha moment for me.
Yeah, and the reason why I suggested that is because you're right. When it quickly gets very complicated, and then you develop the whole thing, you get their flight schedule, you know where they're going, you know when this is happening, and so on. And then they write back after you finish the whole thing and sent it off and spent a couple of hours working on it, and say, "Oh, I have a meeting then. I can't do this." And then you're like, "Okay," yeah, and I remember when I was developing such a schedule for Mr. Jagger, who was going to Japan, and we arranged everything and did all these things for his tour, and then it broke down on the very first day because he didn't follow the things going in New York that he was supposed to be doing, and so on. And then later on, a week later, I got an emergency call that now he really needed, and so the whole thing had to be reworked. But it ended up being very successful once he actually did, follow the recommendations. Of course, it's a little easier when you're dealing with someone who I said, can you put blackout shades on the room? He said, oh yeah, I have a whole crew that goes there a week ahead of time. And I said, can you eat meals at times other than when the hotel is serving the meals? And he said, yes, I bring my own chef. And I can schedule my own plane when it goes there, and so on. That makes it a little easier to make the adjustments if you have those kinds of resources.
But we need those resources in the workplace.
Yes. Yes, exactly.
Private chef or appropriate food even across the night. And I'm assuming that if anyone's doing night work and continuous night work, one of the problems is that the best thing for them, of course, would be to do night work every single day, and then at the weekend also stay on the same schedule. But that never happens, and then because of that, people try to shift because of their home life, and and the body clock can't shift quickly enough, and so you have to have an suboptimal circadian alignment during work weeks and during work days and when you're at home at the weekend. So it becomes really, really tough. So another thing which would be great is if you can shift the clock quickly.
Yes, well, one of the things that I don't know if Frank Shear, I saw that Frank was on the program today. Yes?
No, he's not.
Oh, okay. I misunderstood that. But we published a paper, I think it was in 2022, in Science Advances, which is a very interesting finding related to eating and night shift work. And had I realized that he wasn't speaking, I would have talked about it today, although I wouldn't have had time to do so. But the interesting thing about that finding is that there's a lot of research indicating that there are adverse metabolic consequences to working the night shift and eating at night, and so as a potential intervention, the test was done to restrict eating to the daytime versus eating the meals at night. Now, restricting the meals to the daytime at the usual time that an individual ate is challenging because it sometimes was occurring during the scheduled sleep episodes when they were working at night. But the amazing thing about the findings from that study was that if an individual kept all of their meals at the times that they usually ate them during the daytime and worked at night, that intervention alone was successful in preventing the adverse metabolic consequences associated with night shift work during the limited duration study that was done, whereas those who ate the meals at night like they usually do did experience those consequences. So there may be some interventions that involve the timing of meals that could also help night shift workers avoid some of the adverse health consequences of working at night.
Yeah. I think Dr. McHill showed a slide on that potentially. Is there any other group which wants to report out? Anjali has.
Yes, I would like to. I would like to speak a little bit in my group because I think I did most of the speaking. But I'm Mamaka Cordova, and I was talking about the disconnect between the subjective sleep research on the subjective sleep reporting and the actual not having enough sleep. And I was reflecting really on my younger years and thinking about the inequities of the people of color and the BIPOC community. We have to, I know that I'm a physical therapist now, but how I came about doing that was because I was working, and then I was working a third shift, and after the third shift, I would go to school. And so I remember screaming while driving just to keep myself awake. And so, I talked about that, and I just realized about the inequities that come about from, people who are usually shift workers, and they're trying to better themselves. They're also having other things that they're doing that are, and those things are hard to figure out. What do you do with that? Because, I'm not a traditional go to college right after high school, and you're trying to better yourself, so you're doing two things or having two jobs, and that's a challenging issue to bring about, for people who are trying to better themselves.
Yeah, absolutely right. Anjali, you did have your hand up earlier.
Yeah, I can
Is there
just
something you wanted to share? Okay.
share really quickly. And I think our group, we got into some of the organizational, I think, approaches to it. And one thing that came up is tailoring strategies to workers. And so, and the idea of not just looking at night shift workers as one homogeneous group, but then each person is different, and the way they experience it is different. And so, being able to identify the strategies that can impact or make shift work easier for individuals, for their typical for their specific shift schedules, and also the type of work they're doing. while of course trying to figure out how to tackle overtime, understaffing, all of these other issues. And it came to this, one of the things that came up also is that we're trying to make all these changes around these larger contextual variables like staffing and hiring challenges and things like that. And so the best that organizations can do is to really understand what it is that the workforce is looking for. Why are we having trouble? Because part of what necessitates shift work in some industries, especially extended shift work, is not being able to hire enough people. And so what is it that workers are looking for? Why are they refusing to join or come to join these industries, and understanding the issues that can impact them. And I think Carolyn just made one comment here that speaks to that is, for example, childcare, right? So for women working or for families working night shift, what happens with their children? So maybe workplaces can address those contextual factors like providing childcare. That could go a long way. So it's really about understanding it from a human, a worker perspective, and then being able to address some of these, indirectly at least, address some of these shift work related issues. And I think one other thing that came up is the importance of differentiating between sleepiness and fatigue. I will leave it at that.
Thank you, Anjali. Okay, we have time for maybe one more distilled thought, and then I will. We should close the session at 3:30, but I want to conclude with some remarks. But is there anybody who wants to share something else? David, you have your hand up.
Thank you. We discussed how aviation is very strict with time with shift duration. So that's an industry to learn from insofar as determining when to stop and the staffing levels to keep an operation going.
Yeah, absolutely right. But there are comments in chat, but I think those are comments and not necessarily questions. So thank you everybody for attending. I have written some remarks because I wanted to make sure I hit everything. So I'm going to read them. So as these symposia series that we have are really a highlight for our institute because they allow us to translate research to practice and impact best practices that are ongoing in industries. And so thank you really for joining us, and taking time away from a full work day is hard, and we appreciate you joining us. I really hope you enjoyed this. We enjoyed organizing it. I want to thank everyone who participated and helped organize this event, particularly Amy Spring and Sean McGillis, and Stephen Shea. We had a lot of meetings, and hopefully you enjoyed this as well. We're thankful to all our speakers and participants who helped make it, at least for me, a symposium to remember.